20% of them are on the move at any one point. When over 50 million people move, they move with diseases, they move with commodities, they move with several issues, and public health needs to be addressed in that context. In view of that, there are several other programs that IGAD is working on. And what IGAD has implemented over the last 19 years is adopting the concept of cross-border health systems or inter-country health initiative. This program aims at connecting countries' health systems and ensuring that countries work together. This is seen as one of the premier health programming approach that was adopted by IGAD, and this has helped us as countries, helped IGAD to ensure that countries are connected with a lens of strengthening continuum of care. We have movement of patients or clients with chronic TB, with chronic illnesses across our borders. We, as IGAD and other regional economic blocs, including ECSA, are ensuring that we strengthen cross-border health facilities, cross-border health workforce, cross-border, ensure that we have adequate supply so that when clients move across the borders, they're able to access services. We've strengthened referral systems, and I think this has been one of the issues that has been discussed in the last few days. Therefore, our collective efforts as governments, as regional economic blocs and partners to work together is significant in fortifying health systems against public health threats in our region. The partnership between RECs and government partners is a testament to our collective efforts to build upon the experience that we've gained in countries. There is a lot of experience from the regional economic blocs by member states on how to work together. I think that we need to fortify this. The discussions we've had, excellencies, in the last 1 week has generated excellent technical direction that will be utilized in advocating, but also advancing solutions in health systems, strengthening pandemic preparedness, climate and health. We've talked about maternal health, child health, adolescent health, gender and health, on how to work on this from the regional, from the continental level, regional, national, all the way to subnational level. Of course, we've heard what WHO has said, that we need to have the communities at length. In public health, we say if outcomes are not changed at the community level, it has not happened. And therefore, we need to strengthen our community health systems. The commitment of our ministers' excellencies is a demonstration that we want to work together. I therefore, as I conclude, want to urge all of us to be champions within our respective spheres of influence. We need to be advocates for resilient health systems across the continent, but also within our regional economic entities and also within our governments. Together, as governments and partners, we can demonstrate the power of regional solidarity in safeguarding health and security of our people. Through the commitment and our partnership, let us emerge from this gathering, not only with concrete recommendation, but also a renewed sense of purpose and commitment. Let us be the generation that build a future where pandemic becomes a past, excellencies. With those many remarks, I want to say thank you, and I take this opportunity again to appreciate each and every one of you and thank ECSA for inviting IGAD. I know the other regional economic blocs are not with us, but we look forward to having them in our subsequent discussion. We will also invite some of you to our next ministerial meeting because we want regional economic blocs to learn from each other and countries to borrow from each other within that framework. Asanteni sana, and thank you.
From Intergovernmental Authority on Development, thank you, Dr. Fatuma Adam. You are Madam Chairperson. For now, allow me to welcome the representative from University Research Council, Dr. Emily Baker, for the remarks.
Good morning. I'm very much not Dr. Emily Pekka, but she reminded me this morning that if you want something done, you ask a woman. If you want something said, you ask a man. And so she asked me to say something this morning, and that's my pleasure to do so. So I will just, I'd like to make just really 4 points of thanks to this group. And let me first start by acknowledging and thanking the Director General and the chair of our DJCC, honorable ministers, heads of delegations, and distinguished colleagues. First, thank you for the opportunity to allow us as outsiders to observe this 14th Best Practice Forum and to celebrate with you your Jubilee. Second, we're very grateful for the opportunity we've had to collaborate with you these last 10 years, learning from your very special model on some specific areas that we've worked with: respectful maternal care, urban health, mental health and psychosocial support, and child protection, but also the more general approach to which you have advanced these things. We refer outside to ECSA as the shortest distance between evidence and policy change. And so it's been an experience for us to observe and to learn about how you do that. A third, we're very grateful for what has been the personal leadership of Professor Yauswa and the institutional leadership of ECSA in extending this model of respect and trust and inclusion and informing informing policy into our broader experience beyond in the development of our Global Health Implementation Science Collaborative. And we look very much and depend very much on ECSA's continued leadership in that activity. And then finally, looking forward, we're thankful in advance for the opportunity that we hope to continue to learn and collaborate with you as you further develop and strengthen the colleges of the health professions here in the region. This is a remarkable undertaking, an ambitious and very worthy undertaking, and I think one that there will be great learning here within, but I think as much and perhaps even more learning outside from what you do and how you approach it here. And so with that, thank you.
Thank you very much for the remarks. And for now, before we go to Dr. Jingu, who will also welcome Madam Chairperson, may I give a short break of a short entertainment from Holela Holela Band for like 5 minutes. And then later, I will welcome the Permanent Secretary from the Ministry of Health, United Republic of Tanzania, to give us the welcome remarks and to welcome the Chairperson of the Health Ministries Conference. Holela Holela Band. All of Holela, holela. They will have another session in one of the presentation. We come with another message that dear distinguished guest. And now, Madam Chairperson, with great honor, may I welcome the Permanent Secretary, Minister of Health, United Republic of Tanzania, Dr. John Jingu, will give us the welcoming remarks, and later on, we'll let you speak with conference. Doctor.
Honorable Ministers, Your Excellency, Madam Chairperson, distinguished participants, habari za asubuhi. Habari za asubuhi. Good morning to everyone. And I hope you had a very good sleep and maybe some minutes to go around Arusha and enjoy the beautiful Arusha. Let me take this opportunity on behalf of my minister, Honorable Umi Mwalimu, who wanted to be here this morning, but because of other duty exigencies, she couldn't make it. So she requested me to stand for her, but we hope she might be able to join us at a later stage. So, karibuni sana on behalf of Minister, and we're happy to have you this morning. Ladies and gentlemen, today we are having the 73rd Health Ministers Conference. And we're having this conference after having a very joyful event yesterday. The event which allowed us to appreciate the remarkable achievement which we managed to have in 50 years period. The time where we managed to excel in leadership, but also in collaboration in dealing with health issues, health challenges facing our region and our individual countries. So today, as we start this conference, it is a privilege to us as the hosts to this momentous gathering to reflect our remarkable journey of 50 years of leadership and excellence, but also to see how we are going to excel even more in next 50 years. The next 50 years will be faced with a number of more challenges, the challenges which we see them today, and by the challenges which will also emerge. Currently, as we all know, we have serious challenges when it comes to issues related, for example, non-communicable diseases, issues related with the health financing, issues related with the competencies of healthcare workers, issues related with the healthy threats which comes with climate change, issues related with pandemic preparedness and the response. This gathering is an opportunity for us to build an effective collaboration mechanism, but also, come up with actionable strategies which will help us as the region, as individual countries, to deal with existing challenges, but also emerging challenges. Ladies and gentlemen, in these 2 days, we hope that we are going to have a very meaningful discussion which will help us to develop actionable strategies to address challenges which we face and which we will continue to face. And we believe that our collective resolve and efforts will allow us to build a resilient health system, but of course also come up with effective mechanisms to deal with these challenges. Our shared vision and commitment in fostering a resilient health system will enable us to move more effectively as the region, as individual countries in dealing with these health challenges which we face. Ladies and gentlemen, we believe, therefore, if we do all these things, the next 50 years will be marked with massive achievements. And we wish the discussions which we are going to have today and tomorrow, as the agenda suggests, are going to build a robust roadmap which will allow us as the region to achieve what I've just explained. Massive achievement in building a resilient health system in our region. So with those few words, I wish us, all of us, a productive and inspiring conference. And my assignment was to welcome Madam Chairperson. Let me now take this opportunity to welcome you, Madam Chairperson, This audience is waiting to hear from you. Karibu sana. Asante kwa kunisikiliza.
Thank you. Good morning, everybody. I'm standing in for my minister from the Kingdom of Lesotho, Honorable Sidibe Muchoborami, who could not be with us in this meeting because of other commitments. Honorable ministers from ECSA Health Community, distinguished members of the Directors Joint Consultative Committee, senior government officials from member states, collaborating and cooperating partners, members of the media, distinguished ladies and gentlemen. Let me begin by welcoming you all to the 73rd Health Ministers Conference. The Kingdom of Lesotho is honored to be chairing the Health Ministers Conference for the next 12 months. Today we gather not only to recognize our achievements, but also to celebrate the spirit of unity and collaboration that defines us as a health community. Together, we have achieved remarkable milestones in the past 50 years. From defining regional policy to fostering collaboration and designing inclusive programs aimed at improving the health outcomes in our region. I'm continually inspired and humbled by the dedication, passion, and unwavering commitment each of you brings to our shared vision of a thriving and supportive health community. I am pleased to learn that early in the week, you deliberated on several topical issues related to best practice with the aim of formulating practical recommendations for our consideration as ministers. I'm therefore looking forward to receiving the report of the Directors Joint Consultative Committee in this conference. Honorable ministers, ladies and gentlemen, I want to extend my heartfelt gratitude to all of you who have volunteered countless hours, who have advocated tirelessly for positive change, and who have demonstrated compassion in every interaction. Your efforts have not only strengthened the fabric of our health community, but have also set a shining example for others to follow. We have, over the 50 years, faced challenges that appeared insurmountable, but by holding each other's hands, we triumphed. This is exactly why this health community was formed, to ensure that we work together and aligned with the principle of solidarity. Our challenges are common. They just require joint efforts in addressing them. The ECSA Health Community was founded by ministers of health who felt the need for collective action to address health problems in the region to maximize the opportunities for cooperation. Moved by the growing burden of diseases and competing needs for limited resources in all member states, they saw a need for regional cooperation. During the 4th Regional Health Ministers Conference that was held in 1976 in Maseru, Lesotho, His Excellency, the Right Honorable Prime Minister of the Kingdom of Lesotho then, Dr. Leabua Jonathan, said, "Not only must we stand together politically, but in all things that subserve the common good of our region, whether it be sharing technical know-how in appropriate fields or in the exploitation of greater social benefits for the betterment and well-being of our various populations." Indeed, I want to believe we have kept this vision alive over the last 50 years. In times of challenges, you have shown resilience In times of need, you have shown compassion. And in times of celebration, you have shared joy with open hearts. Your contributions have made a profound difference in the lives of our fellow citizens. I was reliably informed that council members from our constituent colleges volunteer their time daily to support the operations of their respective colleges. This is highly commendable. And it is such sacrifices that have resulted in notable improvements in the health status of our people. Let us therefore continue working together with determination, consistency, and empathy. Let us continue to build bridges of understanding and support. And let us continue to strive for a future where every individual can thrive and find fulfillment. Once again, thank you for your selflessness and dedication. I'm honored to serve alongside such extraordinary individuals as yourself, and I look forward to the continued progress and prosperity of our health community. Honorable ministers, distinguished delegates, with those remarks, let me thank you all once again and declare this conference officially opened. I thank you.
Makofi kama yatoshi. A big round of applause. Thank you very much, Madam Chairperson, Madam Sekpati Monyobi, for this opening, official opening of the 73rd ECSA Health Ministers Conference. Dear ladies and gentlemen, distinguished guests, now we've come to the end of the first session. We'll have a short tea break for like 30 minutes, and we'll be back here sometimes before 11 o'clock. So may I humbly ask the high table to join us for tea break. And in the next 30 minutes, I hope we will be back. Thank you and enjoy your morning tea. Just an announcement to make. In the morning, I said we may have the change of the timetable. The information that has been updated is that the timetable will still be the same as it reads, right? So we will, when we come, we will start with the report of the 14th BPF and the 30th DJCC, which will be presented by Dr. Sultan Matendechero. Thank you. Mm. to start. May everyone please get seated. We are ready to start. Madam Chairperson of the Health Ministers Conference, allow me now to start the second session, plenary session 1. And as we have our program already in your hands, it reads the reports of the 14th BPF and the 30th DJCC. With your permission, may I welcome the DJCC Chairperson, Dr. Sultan Matendechiro, for the report. Dr. Sultan, please.
Thank you, Program Director, Honorable Ministers for Health from the ECSA Health Community, Permanent Secretaries of Ministries of Health, the Director General, ECSA Health Community, Directors of Health Services, Deans of Medical Schools, Directors of research institutions, senior government officials, collaborating partners, members of the Fourth Estate, distinguished guests, ladies and gentlemen. The 14th ECSA Best Practices Forum and the 30th Directors Joint Consultative Committee meetings were held from the 16th to the 18th of February, 2024, here at the Grand Melia Hotel in Arusha. The meetings brought together senior officials from the Ministries of Health, heads of health training and research institutions from the 9 member states, the leadership of the ECSA College of Health Sciences and its constituent colleges, local and international organizations dealing with health matters, program implementers, and diverse collaborating partners from the region and beyond. A total of 154 participants attended the meeting. The Best Practices Forum is a regional platform for the sharing of best practices and promising practices and experiences, as well as research evidence, with the aim of identifying relevant health policy issues and making recommendations to the Health Ministers' Conference towards the improvement of health programming and outcomes in the region. The forum was held under the same theme and sub-themes of the 73rd Health Ministers' Conference, which are 1, human resources for health; 2, NCD's mental health and substance abuse; 3, climate change and health; 4, emerging and re-emerging infectious diseases; 5, reproductive, maternal, neonatal, child, and adolescent health and nutrition; 6, health financing; and 7, technology and innovation in health. Discussions were held both in the plenary and parallel session, focusing on these themes, and roundtable discussions were also held on topical issues, including the health workforce, climate health and artificial intelligence and technology. a fail-first session was held, highlighting challenges and gaps in program implementation and how these can be effectively addressed. And for those who are wondering what a fail-first session is, a fail-first session is grounded on the idea that innovation and success are possible because of our failures. So when we fail, if we have the courage and strength to pick ourselves up and give it another try, we open the door to new possibilities. There were also several country experiences that were shared by member states under each sub-theme. Leaders of ECSA College of Health Sciences shared their experience, successes, and challenges in the training of health professionals in various specialties as a means towards addressing the human resources for health shortage in the region. The forum also discussed building resilient digital health infrastructure, protecting children from violence, and momentum towards upcoming global ministerial conference in Colombia, and the situation on NCDs, mental health, and substance use, among other topical issues. Out of these discussions, the Best Practices Forum came up with the recommendations of proposed action by the member states and the Secretariat, aiming to address the challenges that impede progress towards better health outcomes in the region. The recommendations were further reviewed and refined by the DJCC, and the DJCC further received updates on the second edition of the Regional Guidance on Antimicrobial Resistance Stewardship, a high-level communique of African health ministers of the East, Central, and Southern African region for the UNGA high-level meeting on antimicrobial resistance, that is AMR, which is scheduled for September 2024, will be presented to the HMC at a later stage for consideration. As a region, it is crucial that we take a position on this very important matter to save lives. Indeed, Tanzania has shown us the way with their innovative Holela Holela Itakukosti campaign, focusing on the dangers of irrational use of medicines. This message should reverberate strongly across the ECSA region. Further, a new strategic plan for the ECSA health community was presented and discussed by the Directors' Joint Consultative Committee, who noted the need to emphasize on issues of technology and innovation, substance abuse, climate change, and impact on health, as well as private sector engagement. Honorable ministers, distinguished ladies and gentlemen, the DJCC also discussed the establishment of two new colleges, the College of Public Health Physicians and the College of Family Health Physicians. I wish to express my gratitude to the ministers for endorsing the establishment of these two colleges, which will bring the total number of constituent colleges to 11. I think we need to appreciate that. We applaud the efforts of health professionals who continue to support the collegiate system of learning, which is now one of the flagship initiatives of the ECSA health community. Honorable Ministers, I am also pleased to inform you that the BPF's recommendations were discussed and further refined by the DJCC and will be presented to you probably later this afternoon, pending discussions, most probably. So they may be presented to you most likely later this afternoon for your consideration to pass as resolutions. There was a strong call to ensure that the resolutions are monitored and evaluated so that we can track our progress towards meeting regional and international commitments. May I conclude by thanking you, honorable ministers, for your unwavering commitment to the ECSA health community. I believe we have laid a very strong foundation in the past 50 years, and we will look forward to the next 50 years in fully realizing our aspirations as a health community. Thank you. Asanteni sana.
I thought the applause could be bigger than that. Thank you so much, Dr. Sultani, DJCC chairperson, for the report, well packed. Madam Chairperson, now allow us to start the key presentations, and we have two key presentations for this plenary session one. May I have, the first one is both are in emerging and re-emerging infectious diseases and health emergencies. And the first one will be presented here, Africa position on fight against antimicrobial resistance, our statement to the UNGA HLM on AMR 2024. Dr. Evelyn Sangula, please. Karibu sana.
Madam Chairperson, allow me to stand on the protocols that have already been established and take this opportunity to present to you our proposed position for the high-level UNGA meeting that's coming up in September 2024. And the chair of the DJCC already made a lot of remarks towards that same aspect. I'd like to start this presentation by quoting this very famous person who, because of the work he did, has caused us to come together to have this conversation around antimicrobial resistance. And in 1945, when he received his Nobel Prize, he made a very simple yet profound statement. And he mentioned that it's not difficult to make these microbes resistant. And he said it would be unfortunate when the ignorant man easily underdoses himself. And the chair of the DJCC talked about the Holela band and what they are trying to do. Distinguished delegates, we are already in this era where we have made these bugs resistant. Why is it a global concern now? For several reasons. Over the last couple of years, as countries have been struggling to meet the Millennium Development Goals and also work towards attainment of universal health coverage, as well as work towards achieving the Sustainable Development Goals. But if antimicrobial resistance remains unchecked, poverty is going to be far-fetched because we spend a lot of money using newer, more effective antimicrobial agents. The aspects on food security as well will be threatened. Universal health coverage will also be a problem. Clean water and sanitation
will actually also be a problem because we will not be able to appropriately implement our infection prevention and control measures. Water, sanitation, and hygiene will also be compromised. And the fact that we are seeing a lot of emergence and spread of this new resistant mechanism, our common infections are now becoming untreatable. And the risk for medical procedures, which are currently being undertaken in most of our countries on organ transplant, cancer chemotherapy, and management of other NCDs becomes a problem. So what we are seeing now is that from the conversations we had yesterday, we are not just faced with the burden of communicable diseases. We also have NCDs, the growing burden, and we also have we also are looking at making sure that we are able to tackle all these aspects. When this report was published in the year 2016, looking at the review of antimicrobial resistance, the projection was made and it was published that by 2050, if we don't change the way we are handling antimicrobial agents, antimicrobial resistance will be killing 10 million people every year. And if you look at this other map on this side, the bigger burden is actually going to be within sub-Saharan Africa, bearing almost half the number of deaths per year. And when you look at the distribution of the use of antimicrobial agents, ideally we would think human beings are consuming more than animals. But because of the increased need for food and also working towards food security, we can see clearly that animals are actually consuming 70% of all antimicrobial agents. And we're supposed to ask the question, how much are we taking on the One Health approach when it comes to including the various sectors in our responses? And it's not just that, we are also looking at the quality of antimicrobials that are being released into our markets. Are they effective? Are they also contributing to the problem? And we are seeing that out of the antibiotics that are being consumed by animals, 31 of them are medically important. So if we don't have mechanisms in place to regulate this, then at the end of the day, we will run out of options. There are several drivers to antimicrobial resistance. It's not just the human beings. We are seeing the contribution of IPC, infection prevention and control, through WASH, environmental discharge from pharmaceutical industries, from hospitals, and you're going to see later on how that is impacting the transmission of resistance within the ecosystem. The fish are also not left out in terms of the contribution on the use and the misuse of antimicrobial agents. So we see that the impact of all these aspects at the end of the day boils down to economic damage because of what we need to put in place and the cost we have to incur to effectively treat a resistant infection. Looking at sub-Saharan Africa, this is data from 2019, the global burden of antimicrobial resistance that was conducted globally. A bigger portion of the total deaths attributed to AMR were actually in sub-Saharan Africa. And we were able to identify the leading pathogens being Klebsiella pneumonia and strep pneumonia, causative agents of multi-drug resistant infections and also leading mortality. So out of this study, what was striking was out of the 5 people who died due to AMR, we can see 1 of them was a child. So our efforts in tracking or improving child survival are also under threat. And when we have carried out studies on the use of antimicrobial agents in hospital, we have found a high use of antimicrobial agents in the pediatric population. We probably are using antimicrobials that are not effective. So what that means is that we will have a healthcare system that will be burdened, and you can see from this study that sub-Saharan is actually going to bear a bigger burden in terms of stressing the healthcare system to provide appropriate care. Some of the results I'm going to present are actually drawn from some of the work that was submitted and presented during the Best Practice Forum. And speaking to some of the priority pathogens that we are seeing, and this is a study that has been done in about 5 countries, and you can see 3 of these are our member states. And we could pick out very stubborn microorganisms like Acinetobacter that had recorded up to 83% resistance to meropenem. For anyone who is in clinical practice, meropenem is your last bullet in the gun. If you don't have it, then what we say to the patients ideally is that I have no treatment for you. And if 83% of these bugs were resistant to meropenem, then it's a problem. The next one is Klebsiella pneumonia, one of our priority pathogens. And again, 98% resistance to levofloxacin. And we are seeing in our critical care settings, these are micropathogens that are very hard to eradicate and at the same time exhibiting multi-drug resistance. So the same study also tried to look at surgical site infections. I've talked about the implementation of infection prevention and control measures, and some of our surgical site infections actually arise because of poor infection prevention and control measures. Again, this pathogen has refused to go away, implicated in SSIs in about 31% of the patients that were under study in this hospital. And you can see in terms of cost, if one patient takes 30 to 90 days in a hospital, what's the cost implementation? Not just to that patient, but we extend this to the community as well. And outcomes, you can see at least for all these patients, they were all discharged alive. But in some cases, the patients never make it out of the hospital. So we're also talking about surveillance going beyond the hospital and looking at the environmental aspects. And you can see there are also possibilities of contamination within the environment. Another study that was presented focused on the monitoring of AMR in the environment and specifically within fish and environmental samples. And you can see from the isolates that were actually studied, some of those isolates had carried resistant genes, meaning that there's a possibility of transmission, not just within this particular ecosystem, but also moving this to the human health as well. So in terms of the political declarations and the work that's going on at a global level, in 2015, the World Health Organization endorsed the Global Action Plan on Antimicrobial Resistance. And at a regional level, the Africa Union Framework for AMR Control was also endorsed, and this was followed by the Declaration on the African Common Position on AMR in the year 2020. And as a result of this, member states were encouraged to develop and implement their own national action plans to be able to combat antimicrobial resistance. And there's been a lot of global action following the Global Action Plan endorsement. And we are now working towards the UNGA high-level meeting in September 2024. The first high-level meeting happened in 2016, and since then we've had quite a number of engagements going on at a global and continental level. I'd like to draw our attention to the Muscat Manifesto of 2022. In this meeting, 6 African countries endorsed this particular Muscat Manifesto, and only 2 of our member states were present in this particular meeting. And this highlights the significant absence of the African voices a lot of times when some of these declarations are being made. And we are working to try and amplify our voices so that priorities can also be shaped by what we are seeing within our countries. And we looked at the African countries that have developed national action plans, and you can see tracking from 2017 to 2023, not just focusing on the development, but also looking at the financing to ensure that there is effective implementation. And you can see the color codes have kept changing from a dark green, which means action plans have been developed and are being implemented. And sometimes between 2022 and 2023, the level of indicators went a notch higher, not just to look at the development, but also the financing of these national action plans. We mapped 50,000 labs in 14 countries to look at capacity. And out of these 50,000 laboratories whose capacities are being assessed for their ability to be able to carry out antimicrobial susceptibility testing, only 1.3% had the capacity. meaning there's a significant gap in terms of the capacity to detect and report antimicrobial resistance. So that was a challenge that we noted, and we will see the proposals later. Apart from just lacking the capacity, even those laboratories that had capacity to detect and report AMR, significant gaps were identified in the quality of data that's coming from these laboratories, meaning that we need to put in more effort to strengthen capacity and ensure that the data that's coming out is of good quality to provide necessary guidance for policy and guideline reviews. So we had this regional guidance that was developed as a first edition to support our countries to be able to implement antimicrobial stewardship programs to better use the antimicrobial agents. And you can see a number of countries were able to adapt the regional guidance, which has since been reviewed and hopefully will be endorsed for adoption in the near future. The good thing about stewardship is that you're able to track progress. And for the countries that began to implement stewardship programs, we were able to determine that when you have a structured approach contextualized to our resource setting, we are actually able to see progress in terms of the use of antibiotics. And this can be very well demonstrated by this particular facility that was able to institute an antimicrobial stewardship program. And you can see between the 3rd month and the 30th month, the antibiotic prescribing had significantly dropped, meaning we have the capacity to optimally use these antimicrobials when we have the right guidance and the right tools and support in place. So moving ahead, what we have realized that it's critical to elevate our voices as the African region, because this drives the way funds are mobilized and how they will be allocated right from the global to the national level. And we are looking at raising a banner for accountable governance from a multisectoral One Health approach. And you realize from the data I've shared, there is no animal data from animal health. And the animal health sector has significantly lagged behind in terms of having systems that are enabled to support surveillance for antimicrobial resistance. Then there's the aspect of setting targets and making sure our surveillance systems are working. All this will not be possible if we are not able to adequately finance or mobilize resources for us to be able to address this complex agenda. And of course, we can ride on preventive measures. I think prevention for our region is one of our strongest weapons. If we can invest in IPC and WASH, good stewardship and husbandry practices, we'll be able to prevent the emergence and the further spread. And because of our resource limitations, which limits the access to newer and more effective antibiotics, then it will put our region in a better position. And of course, ensuring equitable access. And I say this because when we have the newer antimicrobial agents, it's very difficult for our population to access these medicines because they are expensive and out of reach more often than not. So these are some of the meetings, and when we've had these global dialogues or conversations and we realized our voices were significantly missing, in collaboration with the Africa Union through the Africa CDC, we are hoping that we'll be able to have a series of engagements. And unfortunately, this 73rd Health Ministers Conference has actually provided the first opportunity for dialogue on AMR and priorities towards the high-level meeting in September. Before the Best Practice Forum, we were able to assemble experts from our member states, and they were able to deliberate on what they thought were priorities for our region and for our countries, and we will be sharing this shortly. And following this, hopefully there will be other meetings within the region, some ministerial meetings. We also hope to have a continental launch of a landmark report that is being worked on with the AU, with the support of Africa Society for Lab Medicine, and ECSA Health Community is also supporting the process. And hopefully we hope that following this conversation, countries will continue this engagement as they prepare their delegates for the high-level meeting in September, where we hope that the health ministers and the delegates from our member states will be present so that we can be able to speak to this issue from a regional perspective. From the conversations we've had over the last couple of days, There are key messages that have come out of our deliberations and hopefully make it into the communique that we can have as a region and push forward as our contribution to this conversation. The first one was the importance of governance, coordination, and accountability, especially from a multi-sectoral perspective. We've realized that there is power in data, not just at a national level, but for use even by the bedside or within the farm. So we propose the strengthening of surveillance systems and their monitoring. And of course, placing prevention at the fore of everything, because this is definitely more cheaper and easier for us to achieve. And again, we'll be able to promote the access to and responsible use of not just antimicrobials, but diagnostics as well. And as we build on other platforms and through the different tracks that we have discussed over the last couple of days, if we strengthen our health systems overall, we'll be able to address antimicrobial stewardship in a better way because it doesn't exist in a silo. And of course, not forgetting the place of research and development and taking advantage of regionality in terms of collaboration, harmonization, and learning best practices from one another. And finally, the place of mobilizing sustainable funding or financing, because without this sustainable financing, it will be very hard for our countries to actually be able to sustain what they're already implementing. So the key takeaways, this is my last slide. We have made definite progress. When we go to UNGA 2024, we are not where we were in 2016, but we are saying that we are not doing enough yet. We need to do a little bit more. And the estimates or the data that we are getting now are warning signals for us, especially in sub-Saharan Africa, where we have a triple burden of disease that we need to handle, in addition to climate change and the disasters that we encounter from time to time. And what the good news is that we have immediate actions. We don't have to wait for funding for some of these actions. With whatever we already have, we can be able to make a lot of good progress. More needs to be done, and I believe with your support, honorable ministers, we'll be able to make a lot of good progress within our countries. And hopefully at the end of the day, we can take a pledge to be antimicrobial guardians, that wherever we are, at whatever level we are serving, we are able to sign up to this pledge card that will come up later on, hopefully, to say that our actions will actually work towards protecting antibiotics, whether it's through practice or through financing or through dialogue or through advocacy. When we join our efforts together, we'll be able to do much more. Thank you. I submit.
Thank you. Thank you very much for the good presentation, Dr. Evelyn, on antimicrobial resistance. Madam Chairperson, allow me now to welcome on the stage our presentation about status of TB in the region, Durban statement and the ministerial call to action. This will be presented sorry for this. I'm told after the presentation, we will now have time to get the message that is part of this from Holela. And I think we have had a very good recommendation from the chairperson of DJCC that you can also take the same across other countries. A round of applause to Holela Holela.
Thank you so much. I promise I'm not gonna sing because my voice is not that good. But the Holela Holela band is gonna sing. Honorable Ministers, Madam Chair, Head of Delegation, Permanent Secretaries, guests, ladies and gentlemen. My name is Waziri Nyoni, and I lead Johns Hopkins University programs in Tanzania. And today, I'm standing here to talk about the Holela Holela campaign. We've heard about the antimicrobial resistance. We've heard about the challenges. We've heard about the importance of prevention. And Tanzania has paved the way in the context of prevention and addressing AMR through a campaign, which we dubbed as Holela Holela Itakukost, which is irrational use of antibiotic is gonna be costly. I'm here to share the best practices in terms of the design. The previous presenter spoke about One Health approach. I can assure you, we think Holela Holela campaign is going to be a good model to share on how the One Health approach can be put in action. This campaign was developed by the leadership of the One Health section, which sits under the Prime Minister's office in our government. And all the sector ministries, Ministry of Health, Agriculture, and Environment, were part of the design of this campaign. And as a result, we've integrated messages, both focused on human health, as well as animals and the environment, and the intersection between the various components. So through this campaign, we hope and expect it will bring a sense of reflection to our target audience. It will bring a sense of concerns and responsibility, and it will inspire action, which is gonna change people's behaviors on how they approach antibiotics, both for providers and our target audience. So the campaign has 3 tiers. We have a component which is focused on mass media, where we use radio, TV, and social media. We have a component which is focused at community, where we've developed various tools and job aids that will be used by community health workers, will be used by religious leaders, and will be used by journalists as well on how they report the issue of antimicrobial resistance. And we have tools that will be used to engage policymakers so that they can prioritize and have conversation on AMR. And we expect through these tools, and when tools are put in action, we have a robust M&E system that will be able to give us data on how the behaviors are progressing in the change category. And today, and over the course of this meeting, you've seen Kido. Kido is our character or an ambassador for the campaign. And through Kido, we are able to challenge some of the social norms, because it's normal for people when they get sick, they just go to a pharmacy and ask for antibiotics. They sometimes go even with a name, but Kido will be able to challenge. We expect Kido would also be able to engage as a cartoon character in our children, so that when parents give their kids medication, the children will ask, why, mom, are you giving me medication without taking me to the hospital or his facility? And the Holela Holela band also, you've heard the song that they were singing, which is Holela Holela Itakukosi song. The rhythm of this song were intentionally chosen to stand out in the media clouded. In our radio stations and in media houses, you will see here Amapiano, you would hear some of these hip hop songs, but this is traditional tune that has been intentionally selected to be able to stand out and deliver the key messages on a Holela Holela. So ladies and gentlemen, that being said, my remarks are over, and now I'm just gonna ask for 2 minutes for the Holela Holela band to sing their Holela Holela song, and Kido to embrace the stage. Thank you so much.
Asante. Asante. Ayo, lela, olela, itakukostie. Why don't we sing a little bit? 1, 2, 3. Ayo, lela, olela, itakukostie. Ayo, lela, olela, itakukostie. Another round of applause for them. Such a great creativity, and be blessed. Distinguished guests, Madam Chairperson, may I humbly take this now microphone to you for the, at least for the action of the first presentation, and after that, we'll go to the second presentation. Karibu sana.
Thank you very much, Program Coordinator. I'll now open the floor for honorable ministers to make comments on the presentations that have just been made. We have had a report on the 14th BPF and 30th DCC report. We have also had a key presentation on the Africa position on fight against antimicrobial resistance. So I'll open the floor for discussions, comments. Honorable Minister from Uganda. Uganda.
Thank you so much, Honorable Chair. Protocol observed as has been set early morning. I want to thank the presenter and all the participants and the Warera group. I have taken key interest to go through, and through you, Chair, I want you to allow my technical team by Dr. Oral Charles, who is part of this, to make observations on behalf of our delegation. I thank you.
Any more comments, observations? Mauritius? Can you pass the mic to Mauritius? Oh, you're still on the floor, Uganda.
Yes, thank you, Chair, through the Minister of Health, Uganda. I think we take note of the report from the Chair and also the high-level statement for the ECSA, for the AMR. And all of us know that this is a global threat for us. The main challenge, I think, as we note, is real. So we really need to undertake, as WHO has recommended, it should be part of the joint external evaluation. And also note that we include not only the aspect of human health, but also the aspect of animal health and environment. So what we want to say that we should be looking at that to tackle antimicrobial resistance. It should be part of the animal one health strategy. So thank you very much for listening.
Thank you, Uganda. Mauritius, you have the floor.
Thank you, Chair. The AMR issue is, to me, similar to climate change. We need a collaborative and concerted action to bring change. What I see here is, from the presentation, that advanced countries and sub-Saharan countries are all involved in this AMR challenge, and sub-Saharan countries seems to be more contributive to this AMR, if I get it right. And the second issue was the animal kingdom, where 70% of the antimicrobial was used, and there's no data really. And I think we need to plan around that as well. It's not only the medical component which is important for AMR issue. Coming to the health sector, I note even in the presentation and previously also I discussed that the private sector, where it is more as much antibiotic use in the public sector, it seems from whatever we discussed so far that the public sector is more responsible or should be the more focused. Obviously, that is important, but I think we cannot neglect the private sector engagement in managing AMR. And last not but the least, I think managing everything is a demand side issue. the patient themselves, the public themselves. And I think Ulela is one way to read them. Because if in Mauritius, at least, it's not the doctor, even insists not giving an antibiotic, the patient insists for the antibiotic. Yeah. So the doctor somehow, because they're in private sector, they are bound to issue that in a way for them to survive on it. But of course, it's not the right thing to do. I think the demand side needs to be really worked on. If the public are engaged and they understand what we mean by AMR, probably this is where the result will come at the end of the day. Thank you.
Thank you very much, Mauritius. Thank you for those observations. I recognize Zimbabwe.
Thank you, Chairman. Let me also thank the presenters for the presentations that they've done. I've got just a very short comment on antimicrobial resistance. During that presentation at the end, there was mention that antimicrobial resistance is now responsible for more deaths, more than HIV. Maybe I would request more information personally. It's a bit worrying if that's the case. Is it a global thing or is it something that is restricted to a particular region? I just want more information on that. Thank you.
Thank you very much, Zimbabwe. I don't know if the presenter would like to clarify on the issue that has been raised by Zimbabwe. Tanzania.
Thank you, Madam Chair. I also want to comment on the AMR. As the country, we recognize the threat and the burden which AMR brings to the global community, country. And as the country, we align our efforts with the global commitments in combating AMR issues. And in this, Madam Chair, we think put more efforts to accelerate production of quality antimicrobials to foster the availability and accessibility, but also to put in more efforts to invest actually on R&D toward innovation development of new antimicrobials, diagnostics and alternative therapies for the evolving resistant pathogens. Chairperson, the United Republic of Tanzania, again, is committed to expand the scope of AMR interventions from national to subnational levels and the community. And this will involve AMR awareness campaigns using Olela and the other campaigns. But of course, also issues related with risk communications, IPC, WASH, and intervention, capacity and the research to inform rational use of antimicrobials under one health approach. And Madam Chair, committed funding for AMR intervention. We have the law which requires us to start implementing universal health insurance to reduce the out-of-pocket spending. So we believe effective implementation of this law would allow us also to contribute in dealing with AMR by implementing interventions which we think they are important in this to this end. QRT is committed toward fostering collaboration with the member states in this fight. And Santa Sana, thank you.
Thank you very much, Tanzania. Thank you for sharing your experiences and your observations. I recognize Honorable Minister from Eswatini. You have the floor.
Thank you, Madam Chair. Maybe may I first start by appreciating the presentation. There is need to strengthen our interventions when it comes to AMR drivers and health impacts. When looking at the health impacts ranging from prolonged hospital admissions to increase in healthcare cost, to treatment failures, it shows that we still have a long way to go. We need to up our game in terms of our interventions. But I have one question as to what informs the figures or statistics that we saw during the presentation. I saw one talking to number of deaths, like 255,000 in the Sub-Sahara. I just want to know what study was done or what informs the statistics or the figures. Thank you.
Thank you, Swaziland. Oh, that's what Tini. Sorry. Do we have any more comments of Zambia?
Thank you, Chairperson. Would like to recommend this wonderful presentation that is making us aware of what we are going through. For Zambia, with just to report that we have got a project with our vet school, which is known as the Africa Center of Excellence of Infectious Disease of Humans and Animals, which is tackling this issue with as One Health. And it's actually promoting quite a lot of training of specialists in research, especially concerning all these things, and offers quite a lot of scholarships. And in reality, we need to collaborate with all these other experts, especially animal health, because diseases actually, we know, are actually moving from one part of animals to human beings, and also document the resistance of also the drugs in animals. Thank you, Chair.
Thank you very much, Zambia. I think we have exhausted all comments and questions. We will now continue the program. You want?
I thought it was.
Oh, you want to answer some of the concerns? Okay.
Maybe I would speak to the statistics. Thank you, honorable ministers, for the questions. And last year, there was a paper on the global burden for antimicrobial resistance that was published in the Lancet paper. And I think we should be able to share the link to the paper so that countries can access the country-specific data as well. And it's through statistical modeling that you're able to project the numbers of deaths as well for the that were attributed to AMR, and also those that were as a result of direct death as a result of antimicrobial resistance. But one of the challenges that we had in sub-Saharan Africa was the lack of robust data collection systems that could not allow us to have a very good and meaningful data. And some of the recommendations from that study was actually calling for our countries to strengthen our data collection processes so that we can have accurate data that can be able to better inform our decisions. But the paper is available, and every country that participated in the study is able to access country-specific data. Thank you.
Thank you, Dr. Evelyn. Program Director, you can continue.
Thank you so much, Madam Chairperson. May you now allow me to welcome on the stage Dr. Patrick Lungu from ECSA-HC Secretariat, who will be presenting his status of TB in the region, Durban statement, and the ministerial call. to action. Dr. Lungu, welcome.
Good morning, ladies and gentlemen. Madam Chair, I ride on the protocol that has been ably shared early this morning, and I stand before you to present on the status of TB in the ECSA region and also a call to action. Before I dive into the presentation, I wish to share that fortnight ago, a group of various TB stakeholders, as well as TB experts across the region, and also the civil societies that are working within the member states, did meet in Durban to deliberate on matters to deal with TB in the mining sector. This was followed up with another meeting as part of the best practice forum, for which we deliberated largely on the aspects of community rights and gender, and also the subject matter of community-led monitoring within the context of TB. And out of that, they voiced out to say that we need to bring to the attention of the honorable ministers of health within our region the status of TB, and also they propose some call to action for your consideration. With that, Madam Chairperson, I wish to proceed with the presentation. So just in this presentation, Madam Chair and ladies and gentlemen, and also honorable ministers, we will be answering where are we with the SDG targets in the ECSA region. And for us to be more focused in looking at where we are, we will look at some of the milestones as well as SDG targets that have been established as global targets, and how we fit in as the ECSA region, and also how the individual member states fit into. So just to illustrate, the first milestone with regards to the NTB strategy was supposed to be achieved by 2030, and this is with regard to the reduction of the total TB death at least 20% when compared to the 2015, which is the set baseline. Further is a reduction in TB incidence by at least 20% by 2020. And lastly is the reduction of the catastrophic health expenditures individuals seek healthcare for TB. So we have the 2020 milestones, the 2025 milestones, and also the SDG 2030. So you can already see that we already have one, if not 6 months to go before we evaluate how we have fared on the milestones to be on the 2 milestones to be achieved. So I wish to share some positive development within our region, that 4 of the ECSA member states have reached the first milestones of the NTB strategy, which is the reduction of TB mortality. And these are Kenya, Uganda, the United Republic of Tanzania, and Zambia. Again, another landmark achievement by 5 of our member states that have achieved the first milestone in reducing the TB incidence by 20% when compared to 2015. And these are Kenya again, Lesotho, we have Zambia, Zimbabwe, and the United Kingdom, or the United Republic of Tanzania. Another big hand of applause. So indeed, we're making progress within our region in the space of TB. But however, I want to share with you where we are as the African region. TB is one disease that transcends across the frontiers of our borders. So we need to be wary or aware of what is actually happening across Africa. So again, Africa again continues to shine, but as you can see by the green line there, that the TB incidence in Africa is falling. And also the TB notifications are starting to increase, getting closer to an estimated burden. And also, again, the TB incidence within the HIV population as well continues to fall steadily. Further to that is the reduction in HIV mortality. But of course, I think we may not be so pleased with the reduction. We'd like actually to have a much more steeper reduction. I want to share with you a more concerning statistics, and I think this is a scenario that we all need to change, or rather a narrative that we need to change. That 25% of the global burden of TB is within the Southern Africa. And all the ECSA member states are heavily burdened by TB, as you can see by the deep purple color there. The deeper it is, the bigger the burden of TB is. So I also want to share with you that in our region, the two major drivers of TB are undernutrition as well as HIV. We should even be more concerned with these two drivers, especially the one on undernutrition. Currently, if not recently, some of the member states of ECSA just underwent a drought. So which therefore signifies or indicates that potentially the issue of undernutrition is likely to be magnified. That in itself starts to potentiate the issue of TB. So if anything, we should anticipate the burden of TB being possibly escalated by what we are seeing as the effects of climate change. Just to share with you a study from two of our member states, which was done in Zambia and Uganda, where they found that the TB prevalence in children with severe acute malnutrition was 17.9%, a very huge. And if we are to flip the coin by saying, what is the prevalence of undernutrition in TB? Perhaps it will even be above 70%, if not 80%. So this is another aspect we need to be hugely concerned. But I also want just to bring you to the attention of this August House, the issue of TB and the mining sector. The miners are 4 times at risk of suffering from TB when compared to the general population. And for miners who are actually living with HIV, this actually goes to 15-fold. In simple terms, 15 times the risk. So essentially, we need to be wary of these drivers of TB in our region. As you know, most of their economic activities in our region is largely mining. So we should be concerned with what is actually happening to miners and instituting the primary preventive measures of TB in that sector. This is another concern in the sense that TB is affecting largely the economically viable age groups, and that's the age group of 25 to 34, 35 to 44. And these are the ones that are equally largely involved in mining activities. So this in itself, not only, it has an economical effect in our setting. So I just want to share with you some of the statistics coming from the WHO that out of the new cases of TB in Africa, we are only reaching 70%. Why should we be concerned? The 30% that remains undetected, untreated, continue to drive the TB burden in our sector, in our region. Second is that we are still recording huge TB-related mortality in tune of at least 17%. So TB in our setting remains a huge public health problem. This is another issue in Africa or in our region in the sense that there are novel and high impactful interventions that have been proposed by the WHO. But as Africa, we are slow to uptake these high interventions that are life-saving. If I can just simply cite one of the interventions meant to enhance TB diagnosis in children. At the time we were reviewing the data, only Zambia in the region had started the programmatic implementation. The other countries were either planning or undertaking the validation. So this is just a surrogate of various others. If I could even also dive into the BPA, which is a regimen meant to save lives of those suffering from drug-resistant TB. Other than in the Southern Africa, other than Eswatini, and South Africa, the other countries have yet rolled out the shorter and patient-friendly regimen that is meant to save the lives of those that are suffering from all forms of drug-resistant TB, especially those with MDR and XDR as well. So we are slow to take up the WHO recommendation, and that in itself should be a huge concern to us. At the backdrop of all this is that the funding for TB is actually declining. As you can see, while we still have a bigger problem, the allocation of funds, especially from the domestic basket, is going down. We should be concerned with that. Without finances, we cannot intervene. So TB requires to be refinanced and funded adequately. Actually, if we are to actually benchmark the funding against what is indicated in the costed strategic plan, the situation is even more worrying. This is actually just showing what is absolutely allocated and not against the costed strategic plan. If we are to go that route, we actually have a more worrying situation because the TB strategic plans in our settings are largely underfunded, hence the situation that we're seeing here. So I just want to do a quick dive into how the TB situation is in the member states. As you can see in the case of Mauritius, I think the burden is not so huge, but you can see a steady situation with regard to TB incidence, and also HIV-related mortality is declining. Of concern in the case of Mauritius is that they are only finding 76% of the new estimated TB cases. So about 24 cases are not linked to care. In the case of Eswatini, remarkable progress that they made getting up to 2016. And this, you can see the huge decline is the issue of addressing HIV. And this is why the HIV collaborative activities must continue. But what we see there is that the TB incidence has plateaued. Similarly as well, the mortality in Eswatini has also plateaued, so it's not going down. Of concern is that Eswatini is only reaching 61% of the estimated new cases of TB. 39% remain undetected and unlinked to care, hence driving the burden within the Kingdom of Eswatini. In the case of Lesotho, we start to see TB burden starting to go up. And partly this is a result of what was the gaps around COVID, where we saw that there was reduction in TB case detection in the case of Lesotho. And linked to that is that mortality correspondingly is increasing. And another thing of concern is that they're only reaching 37% of the estimated cases of TB. Lesotho has a unique situation in the sense that it's a very mountainous country, and certain parts of the country in certain seasons becomes hard to reach. So Lesotho may need to actually tailor-make interventions as per their situation. It's a very challenging country to provide interventions, but nonetheless, some tailor-made interventions could be made. In the case of Malawi, again, TB incidence has plateaued. I want to say this is that when the plateauing of the incidence comes as a result of reduction in cases being found. So with the plateau, things could actually go either direction. If there are lesser interventions, the incidence starts to go up. If you are intervening more ably, the incidence starts to go down. And you can see that mortality is correspondingly going down, but in a reasonable fashion. Another concern is that only 71% of cases are being reached. In the case of the Republic of Tanzania, quite remarkable progress. We see a steady decline in TB incidence with a corresponding increase in TB notification. That's a desirable situation that we'd like to see, and mortality corresponding going down. But work needs to be done around case finding, where only 77% are being notified. In the case of Zambia, some landmark and remarkable progress, incidents going down, and also with a corresponding increase in TB notification, a huge decline in TB notification. What Zambia did is they increased their TPT coverage, a good performance of TB. They are reaching at least 92% of the estimated TB cases, reaching the WHO threshold or set mark of TB notification. Zimbabwe, we also start to see an increase in TB incidence between the years 2021 and 2022. And this is partly as a result of the EU effect of COVID-19. And also we see a corresponding increase in TB-related mortality. As also we saw in other countries, Zimbabwe is only finding at least 55% of the estimated TB cases. In the case of Uganda, another remarkable progress that has been recorded, incidence though has remained steady, but we see a good case identification in Uganda and also a good reduction in TB-related mortality. You see a very surprising result where Uganda is actually reaching every one of those that are estimated. In the year 2022, they had notified over 94,000 against the 90% estimated new cases. So Uganda may need to consider undertaking a prevalence survey to better inform the estimates as they are reaching all the estimated. I wish to share quickly some of the impactful interventions that ECSA has supported the member states. And number one, I would like to single out the cross-border referral system. I want to qualify this to say this is a SADC initiative of which ECSA is providing technical support in the implementation of the cross-border. Eduma from IGAD talked about the importance of cross-border collaboration in our remarks. The cross-border collaboration serves us to actually systematically refer patients with TB across borders for the continuum of care. What is currently obtaining is that patients who transcend across the borders are only doing the referrals by self, which in itself is resulting into the loss of these patients, hence driving the DRTB epidemic in our setting. Another landmark support to countries by ECSA is the study on catastrophic health expenditure, speaking to the aspects of health financing and removing the barriers linked to health seeking when the individuals have TB, and also speaking to one of the SDG goals. From this study, what has been established is that patients in our region, if we are to use the studies conducted in the 4 countries as our surrogate, is that patients with TB are actually experiencing high catastrophic health expenditure as they are seeking health care for a cause attributable to TB, a huge concern. So for us to ably respond to TB, we need to remove these financial barriers that are existing. So in summary, what we observe from the TB situation in the ECSA region, the SDG targets about TB are hugely off track. Secondly, we observe that TB interventions, including those in the mining sector, are underfunded. We also realize that the regional response is of utmost importance for cross-pollination of ideas and to better coordinate the TB response in the region. I wish to qualify that to say that no single country will respond to the TB epidemic ably without a regional approach. So we cannot substitute a regional approach in the TB response. The call to actions that have been proposed is that we've proposed this before the honorable ministers, that there should be urgent improved access to TB services. As you saw in all the individual countries that other than Uganda and Zambia, the rest of the ECSA member states are only reaching at least 37 to 70% of the estimated new TB cases. So we need to urgently address this particular issue. This then speaks to the issues of TB financing. There is an urgent need as well to increase domestic financing to enable the TB response in our region, not only the general TB, but also TB in the mines. Thirdly, accelerate the adoption of the WHO recommendation, as it was alluded to in the presentation, that countries in the region are slow to uptake the WHO recommendation. Fourth is support this noble and innovative innovation of the cross-border referral for TB patients across the region. Fourth, as we embark on this noble journey of responding to TB, is that we employ a human rights-based approach, taking into account or into place community-led monitoring, the aspects of CRG. And lastly, we would like to appeal that the honorable ministers advocate for the Global Fund and other international donors to earmark funds to support the TB response in our region. And also, as they earmark funding, they also prioritize the aspects of TB in the mining sector. With that, I would like to end with a mantra that while we see a bigger problem, it is possible to end TB. And I would like to read the mantra, yes, we can end TB. I thank you for your attentive listening.
Thank you, Dr. Lungu, for that elaborate presentation on the status of TB in our region. At this juncture, I would like to open the floor for discussion. Maybe I'll start with my country, Lesotho. You know, we have a high incidence of TB, and the challenges that have been articulated by Dr. Lungu, they are really what is on the ground in our country. But we are making efforts to find missing cases. We have mobile clinics that we use to go into the districts to find missing cases. But our mobile clinics can go up to so much because of the terrain of our country. We cannot reach all the populations during using those mobile clinics. There are some places which can only be reached by helicopters. There are places which can only be reached by horseback. So we really have a problem of reaching our people in Lesotho, but we are trying. The Ministry of Health has also engaged on the integration of health services. So when a person gets into a health facility to seek treatment, maybe for HIV, he will also be tested for TB, tested for cancer, so that we treat a patient, not a disease. Otherwise, I think we are trying all we could. But the other challenges that we have is the challenge of funding. We have seen that the funding from our development partners is being reduced. And I think it's high time that our governments inject more capital into the TB program. We also have a challenge of human resources. We need to employ more resources. We are embarking on the restructuring of the health ministry. And according to that report, we have a vacancy factor of 52% in the Ministry of Health. So you can see that we really have a challenge. I'll stop here for now and open the floor. I recognize Uganda.
Thank you so much, Madam Honorable Chair. And allow me take this opportunity to thank the presenter for a well-structured paper that has covered status among the ECSA member states. The status burden of TB in Uganda, I wouldn't want to dwell on it so much. The presenter has quietly brought out the status of TB and the leprosy in Uganda. I only want to say and confirm that Uganda is among the 10 countries globally that have the highest TB burden, Madam Chair. So once you are also on your other side, your counterpart, Uganda, is also having the same burden. And what we note as Uganda is that the highest burden is among men, other than women. At the same time, it has not spared the small young children also. You'll find that 16 of the children out of 100 are patients of TB, which is more worrying and which needs attention. So they are our small new generation that the highest risk. And in Uganda, 53% of our people experience financial constraints. One is TB is costly. At the same time, this is where you have to stay a long time on treatment. And as the campaign of Wolera is ongoing, this is another area where the TB patients don't stay on drugs because of such finance costs and other issues. So they break out. Then when it is out of stage, that's when they can seek. And of course, that one goes with let's detect it among the communities. Uganda's achievements, well, the president said it, but that we are among the countries that have made significant progress, though a lot is still needed. Like in many other countries, the progress is there in accordance towards achievement of the United Nations high-level meeting, which targets that the reduction of TB. And that's where all of the countries must focus. And as Uganda, we have interventions made, as the presenter has rightly put it. Uganda has a patient-centered TB responsive multi-sector. This is where all the sectors, education, gender, they come together and make a multi-sector ministerial committee, which is trying to address TB in our country. Prevention and management and control across the border, TB border. The presenter has said it, Uganda is known that we are really have cross-border diseases, TB is among them. So we have intensified our community awareness. It's very important, as the presenter has said. Yes, we can ensure that TB is eliminated, because it can. And this we can do it when we bring participation of every stakeholder, the communities, our leaders within the communities, religious leaders, the different participants, and the media. Because what we need to do more is we must focus now in this era towards prevention other than treatment. And this is an area that we can go in. Finally, as Uganda, we are looking at increasing of the medicines, not only medicine for TB, but medicine that is quality medicine. My only issue here is even when the presenter was presenting, he said little or nothing about leprosy. And TB and leprosy, they go together. And we have come to establish that there are so many cases, patients of leprosy in our communities, which are very silent, which are not attracting any funding, if at all. And I agree with the presenter that we need to do much as the region, especially on the urgent action. So I strongly and totally agree with the presenter's call for action, especially in increase in funding in our budgets and increasing in our technology for early detection, and of course, awareness about TB and leprosy as related cases. And at the same time, it's my call that I wanted to hear and to discuss about the raw detection for drug resistance. It's now noted there's a lot of drug resistance among the TB patients. So if we could cover on that one and take it on, we would be happy. But on the whole, TB in our region is another case that we should take seriously and as a priority area when we are dealing with our public health care and the way of management. I thank you.
Thank you, Honorable Minister from Uganda. I recognize Malawi.
Thank you, Chair. Honorable Ministers, heads of delegation. First of all, I'd like to thank the presenter for the good presentation. I can see that we're making a lot of progress as a region. So as for Malawi, I would like to ask my Secretary for Health to make our statement. Thank you.
Thank you, Honorable Deputy Minister. Thank you, Chair, Honorable Ministers and heads of delegation. Indeed, the fight against TB is a big one. As a country, we recognize that the fight needs a lot of stakeholders and needs collaboration. Now, quickly go through what we have done as a country. Malawi has initiated several interventions to ensure that people access TB services in their communities, such as house-to-house TB screening, TB contact tracing, mobile diagnostic units, as well as community sputum collection points. The ministry is also working strongly with the media fraternity to ensure that TB messages are provided to the people through all appropriate and effective channels. Through the public-private mix approach, Malawi is also strengthening its working relationship with private health sector providers to ensure that TB services are available for all. As a country, we have made significant investments in mobile diagnostic vans. So these are vans that move across the country, providing services, digital health to ensure more efficient recording and reporting, infrastructure and equipment, including procurement of gene expert machines, X-ray machines to aid in diagnosis. On capacity building for our healthcare workers in diagnosis and treatment of TB and leprosy. We have also done on capacity building for our health workers in the diagnosis of TB and leprosy. Chairperson, honorable ministers, heads of delegation, we have also engaged in scientific and operational research in TB for evidence-based practice, better tools and better service delivery. Despite these numerous investments, more needs to be done if we are to attain our vision of being Malawi without TB by 2030. In terms of financing, as a country, we realize that the health sector is mainly funded by external donors. And as a country, we launched our health financing strategy last year. We have conducted a number of health financing dialogues. The aim is, what we're aiming to achieve is to increase domestic financing for the health sector. In conclusion, Malawi is committed to ending tuberculosis. Lastly, I want to take this opportunity to thank our partners, the Global Fund, World Bank, USAID, WHO, CDC, UNES, the Malawi Liverpool Wellcome Trust, the Kamuzu University of Health Sciences, and all other partners. Thank you.
Thank you, Malawi. I recognize Honorable Minister from Eswatini.
Thank you, Madam Chair. I would like to report that on the 14th of June 2024, that is last week, we launched the TLC Nkwe Medical Drone Network in Eswatini. And we hope it will significantly contribute to efficiencies in health service delivery. The drones are used for delivery of essential supplies like TB drugs and response to epidemics and reaching remotely located settlements. I hope my neighbor Lesotho will consider coming to Eswatini for benchmarking.
That an invite.
So we hope we will realize a better coverage in the not so distant future. Thank you.
Yeah, thank you, Eswatini. I think we have exhausted all our comments. We have, oh, sorry, Tanzania.
Thank you, Madam Chair, for the opportunity. As the presentation shows, Tanzania has made notable progress in introducing new cases, and of course, also deaths related with the TB. But TB remains a public health problem, just like in many other countries in Africa and elsewhere. And in our view, the crux of the matter lies with the resources, availability of adequate resources, which will allow us to implement various interventions related to the prevention and the treatment of the disease. And in this, we have come up with the two major options. One is the universal health insurance. And I believe this is across. And that is something which I believe if we share experiences among ourselves, we'll be able to implement universal health insurance in our countries in a way that will allow us to mobilize enough resources to strengthen our health systems in dealing with health problems, including TB. So that is one area which we think it will help us generate enough resources, deal with the problem. But of course, we are also thinking of, and not all thinking, we have started leveraging private sector to mobilize the resources from the private sector. And the private sector here, it includes even traditional healers. Yes, they are key people, for example, in identifying patients, patients identification. Private sector may help us mobilize adequate resources, but of course also implement various interventions that they be prevented and the treatment. Thank you.
Thank you, Mauritius.
Yeah, thank you, Chair. Some clarification from the presenter, please. I just wanted to know what is we have been talking about AMR and AMI with tuberculosis drug. What is the status on an average in the sub-Saharan region? Because from there, a lot of things may change. Because if we have too much of drug resistance, and we have to find ways and means of tackling that issue. As for Mauritius, I am aware that drug-resistant tuberculosis drug is there, and it is getting to be more difficult for us because more and more expatriates are coming to work from the African continent, from Bangladesh and India to in Mauritius, and where tuberculosis is quite endemic. So this is one thing I wanted to share with you. Thank you.
Thank you for sharing, Mauritius. I think we have come to the end of this discussion. We can proceed to. There was a question. From where? Yes.
Thank you. Chair, I may wish to request to react to the comments coming from the Honorable Ministers of Health, and also just to thank them for their remarks, and also for also sharing how they perceive the TB situation in the individual countries. I may wish to start by also just qualifying what the Honorable Minister of Uganda said about children. And I want to request that we should not misunderstand the Honorable Minister of Uganda. Actually, what she's referring to is that 16% of the total TB cases that are notified, 16% are children. Actually, WHO has benchmarked that the burden of TB or the total notifications, at least 10 to 15% must be children. So we should actually commend Uganda for the efforts that they are putting into finding TB in children, and probably learn from what Uganda is doing by finding and meeting the WHO benchmark with regard to TB in children. May I also seek your permission to react to the remarks by Mauritius? Indeed, we know the statistics for drug-resistant TB. So besides the drug-susceptible TB, our region is also facing a huge challenge with regard to drug-resistant TB. If you pick up, especially in the southern part of Africa, some countries are like South Africa are recording in excess of over 10,000 cases of DRTB per year. That's a huge. But of huge concern with drug-resistant TB is that if not all countries, we are under-detecting. And secondly, those that we are detecting with drug-resistant TB, we're only managing to treat at least 66% successfully. So there's a huge TB-related mortality as a result of drug-resistant TB. And this speaks to the Olela subject matter that we had in the morning, which is the AMR. So even within the context of TB, we need to heavily prioritize the aspects of antimicrobial resistance. And perhaps maybe just to request that as the region deliberates on the matters of AMR and TB should be included, especially with the aspects of drug-resistant TB. So in a nutshell, certainly the region is facing a huge burden with regard to drug-resistant TB. I thank you. I thank you, Chair.
Thank you, Dr. Lungu. Okay, you have the floor. You got.
Thank you, Chair, Honorable Ministers, all protocols observed. I just want to briefly share the regional cross-border perspective of TB and what is happening in the Horn of Africa and the IGAD. And I want to pick from where Uganda has left. On the request, Honorable Minister, on your request on DRTB, this is noted under IGAD. I know ECSA would also be supporting, but we will take up that and convey that request to our TB program. Honorable Ministers, I think I don't want to go back on the burden of TB. It has already been overemphasized. But on cross-border TB, what we've learned over the last 10 years in implementing TB is one, cross-border TB needs to be localized. And when I say localized, I think we really have to take it closer to the actual borders, and we need to build the capacity of the facilities at the border and increase the number of diagnostic facilities in our border areas on both sides. The other thing that IGAD has learned through the member state is we've intentionally invested and supported our national TB programs, and we actually have cross-border TB focal persons in each of our NTPs. And this has really helped us support the programming. The adoption of cross-border TB referral package by our government has also been very instrumental. And I want to commend the government of Uganda for having included the regional cross-border referral tool in their national TB strategy. And that is how Uganda has been able to move forward. The other experience we've learned over the last many years is there is need to invest in refugee TB, cross-border TB, but also TB for people on the move. Those are different classes of individuals and population. I think our member states and funding entities must support governments and NTPs to classify those groups of individuals and have tailored response for each. For the Global Fund request, we have window and IGAD has received the third grant. I think other regional economic blocks can explore on that, and we can build on the lessons that we've had from Global Fund funding regional response. Thank you.
Thank you. IGAD.
Thank you. Thank you very much for the presentations and the contributions from honorable ministers. According to the little discussion we had with the chairperson, we have come to think that we can at least add the plenary session 2 before we go for lunch, so that when we come back, at least we don't have much in the plate to finish up. Madam Chairperson, do we stand with that? Will be flexible because of the discussion comes here, but I believe we just reached some decisions for better. From the instruction that I get now, it is suggested that we go for presentation and adoption of the resolution, right? And then when we come after lunch, we will finish up the others. So I take this back to your chair, Madam Chairperson, to go ahead with the other instructions. Thank you.
Thank you. Okay, Martin. Where is Martin? He's the one who's going to present the resolution of the conference. That's from Honorable Minister Uganda to consider the resolution before we go for lunch, because she might probably be not available after lunch. That's why we are getting into the resolution.
So we buy a little time before we have the presentation now. Just some minutes.
You can go ahead.
Yeah, thank you very much, Madam Chair, honorable ministers, senior officials, all protocols observed. I would like to ride on the protocols that had already been established, and I'll be sharing the draft resolutions that came from the discussions that we had over the last couple of days in terms of the discussions and the conversations that emanated from the Best Practices Forum. As had been indicated previously, from the current year's theme, we had a number of sub-themes that were discussed during the Best Practices Forum. but also just before the BPF, there were some pre-conferences that were undertaken on various thematic areas, including some of the discussions that you previously had in the morning in terms of AMR and also the aspect of TB. So I'll be taking you through the draft. Of course, we came with some draft recommendations from the BPF that were discussed at the floor during the closure of the BPF forum. The recommendations were further discussed by the DJCC in their closed session. And of course, they were refined further. And I'm sharing part of the draft resolution that came after the comments that came from the DJCC. So if you allow me, I'll skip the first part. I'll skip the first part and go straight to, because we are updating that preamble to reflect on the part of the opening session that happened this morning. Go to the sub-themes for this conference. Yeah, stop there. So we had 7 sub-themes: human resources for health, health financing, emerging and re-emerging infectious diseases and health emergencies, reproductive, maternal, neonatal, child, adolescent health and nutrition, non-communicable diseases, mental health and substance use, and mitigating the effects of climate change on health, and also the use of technologies and innovations in health. Now, following the discussions, we came up with 12 draft resolutions as listed there. You will notice some areas like the emerging and re-emerging infectious diseases and health emergencies is quite broad. So in the discussions, 3 draft resolutions came out of that particular sub-theme, as well as the RAMCA and nutrition. So the aspect of nutrition became a big issue, and therefore there's a separate draft resolution to that effect. So if you could scroll down, stop there, so that we see through the draft resolutions. The first one, ECSA-HMC 73 Resolution 1, and these are drafts. I'm saying that with caution. Building skilled human resources for health towards attainment of universal health coverage. The second one is health financing to build resilient health systems, emerging and re-emerging infectious diseases and health emergencies, strengthening implementation of national action plans on AMR, RAMCA, nutrition for promoting health and development, non-communicable diseases, injuries, mental health and substance use, mitigating the effects of climate change on health, and then technology and innovations, sustaining the interventions for TB in the mining sector, and 2 resolutions that expresses gratitude or appreciation to the partners that have been supporting the member states, as well as supporting us to deliver on our mandate, as well as appreciating the support that has been offered by the government and people of the United Republic of Tanzania. I will go to the first draft resolution, so you can skip the acronyms. So ECSA-HMC Resolution 1, HMC 73 Resolution 1, building skilled human resources for health towards the attainment of UHC in the region. We are cognizant of the critical role of HRH in ensuring resilient, sustainable, and responsive health systems. We are encouraged that the approaches and strategies for sustainable solutions for HRH and quality of numbers that the various institutions are producing, including the collegiate model that has been tested. We are aware of the current status of retention of the specialists based on some of the studies at the College of Surgeons and as well as the other colleges that show that about 88% of the specialists trained at those sites are retained. We are appreciating the efforts that have been made by the various colleges and providing some standards to improve on quality of training. But we are also noting that that limited number of member states recognize the ECSA College of Health Sciences affiliate professional colleges, trainees and graduates, which delays their registration and practice, which is something that we need to take care of. We are aware of also impeding low female enrollment and graduation rate, which is at 21%. We are mindful of the need to improve the quality of physicians and family physicians through public health and also family health training. We are also noting the efforts that have been made towards the establishment of colleges related to that particular need. And then we are also concerned that a number of trainees from these colleges receive scholarships while this particular kind of training is needed, and also critical services are needed for specialists in those particular areas. Of course, there's limited support to facilitate training. We are mindful that there are previous resolutions that had been made that speak to this particular topic. Resolution number 4 of HMC, the 25th HMC, as well as resolution 2 of the 26th HMC that call for establishment of regional professional colleges. So we are speaking to the mandate that was given through those resolutions. Resolution 3 of HMC, the 40th HMC, that urged the member states to define human needs and standards and improve standards of staffing for different levels. Resolution 4 of the 42nd HMC, and we are also recalling resolution 5 of the 62nd HMC, which spoke to the issues of innovations in professional training. If you could scroll down further, resolution 1 of the 67th HMC that urged the member states to explore a linkage of health, that directed the secretariat to undertake labor market, the workforce studies and undertake periodic reviews, and also other resolutions, including last year, that spoke to a number of aspects. So we note progress has been made in terms of the implementation of the previous resolutions. However, we still have some gaps, and we are aware that addressing these gaps require full and accelerated implementation of the past resolutions. And therefore, the HMC urges the member states to approve the establishment of the 2 colleges, the ECSA College of Public Health Physicians under the ECSA College of Health Sciences umbrella, and also approve the establishment of the College of Family Physicians to operate under the same umbrella. Also urge the member states to support the operationalization of the College of Health Sciences to facilitate full recognition of specialist disciplines qualifications by the national Something has happened. Let me just read it from directly from my computer. So the first this proposed resolution is support operationalization of the College of Health Sciences to facilitate full recognition of specialist disciplines. And this is in line with that particular concern that had been raised in the preamble in terms of the recognition in a number of countries. Of course, some of the countries have gone ahead and supported this particular initiative, and the trainees and the graduate have been recognized, but a number of the countries we need your support, honorable ministers. We are also requesting member states to promote implementation of gender inclusion and mainstreaming in the programs, owing to the low number of graduates that are female graduates coming from these colleges, and also develop and implement strategies for absorption and retention of these specialized human resources for health that are critical, and especially in the hard to reach areas, considering even the level of retention from the graduates of these colleges. And then the HMC to direct the Secretariat to support the member states to accelerate the process of harmonization of standards and guidelines for the various colleges, and also even beyond this collegiate model, facilitate engagement between the Ministries of Health, Ministries of Education, and other relevant bodies to facilitate the full recognition of the collegiate model, considering the needs that are there and the shortage that we have for the specialized human resources for health. And then develop a monitoring framework, monitoring and evaluation framework to track progress of implementation of the past resolutions and report during the 75th Health Ministers Conference. This particular item was suggested by the DJCC so that we can be able to track where we are and how we are moving. And it's reflected in all the resolutions. And then support the member states to implement the above as well as the past resolutions. Madam Chair, I wish to submit on the past draft resolution for consideration.
Thank you very much, Martin. The DG wants to make a few comments.
Thank you, Madam Chair. Not really a few comments, just to indicate that in the presentation, the format of the action points was a bit distorted. The first two action points on the establishment of the colleges are for the conference. Then what follows subsequently are actions directed to the member states, directed to the Secretariat. That is what the text implies, and that's the spirit in which this should be handled. Thank you.
Thank you, DG. I now open the floor for discussions and comments. Malawi. It was from the previous. Uganda.
Thank you so much, Honorable Chair, and I want to thank the presenter of the draft of the resolutions of the 73rd Health Ministers Conference. I want to associate with that one by the Director General and correction input of the picture. On Uganda's behalf, I want to say that the resolutions is the true picture of what transpired. And I want to associate with the resolutions and look forward for their implementation. I thank you.
Thank you, Honorable Minister. Is there any other comment? I don't see any other comments. Thank you very much, Martin. I think now you will incorporate all the comments and complete the draft.
Yeah, thank you, Madam Chair. I take that with that, the first draft resolution is now adopted as a resolution subject to the
Yes.
corrections that will come through. And
Not yet. No, I want the I want the ministers to move for adoption of the draft.
okay. Okay, thank you for that guidance, Madam Chair. So you can take me to resolution 2. Honorable ministers and distinguished delegates, the draft resolution 2 is on health financing and building resilient health systems. We are noting that the Abuja Declaration of 2001, which set the target of allocation of at least 15% of the national budgets to improve healthcare. We are further noting that there are some estimates by WHO, which states at least 112 USD per capita is the amount needed in the low-income countries for all services and interventions needed to achieve the health-related and sustainable development goals. We are concerned with the slow progress by the countries towards meeting these targets, of course, based on the findings and the reports that have been discussed here. And we are further concerned on the low expenditure on health, which fall far below even the 2018 estimates of $90 per capita. We are noting the existence of financial barrier to accessing primary health care, including the catastrophic health expenditure by citizens in the region. And I think there were some findings that showed quite a huge level of catastrophic health expenditure, and especially on TB, but it also cuts across other disease spectrum. We are aware of the commitments that the countries have made, including those that were made during the 72nd summit of the African Union in Addis Ababa in 2019 that set ambitious targets, including the attainment of UHC by 2030. We are cognizant of limited skilled human resources to perform economic analysis and modeling that will help us get findings that will help us to invest in high impact interventions for UHC. And we are also aware of the pressure that the climate change and other natural disasters have on the cost of delivery of health services, also noting that we still are challenged with the gathering enough evidence to be able to inform our interventions. We are recalling that previously there had been other pronouncements by the health ministers, including Resolution 6 of the 42nd HMC that urged member states to develop comprehensive national health financing strategies. Resolution 6 of the 44th Health Ministers Conference that urged member states to enhance performance of the health systems to attain the MDGs then. And then the aspect of health financing and equity in maternal, newborn, and child health during the 56th HMC. And also in 2015 and 2018, there were also other resolutions related to universal health coverage using innovations as well as priority setting and health preparing health benefit packages to improve on this particular issue. So we are recognizing efforts that have already been made in enhancing financial protection of the citizens by establishing and instituting health insurance schemes within the countries, as well as efforts towards attaining UHC. I think most of all the countries already have programs that are driving towards attaining UHC. However, we note that the member states are not on track in terms of attaining the 2030 commitments, and therefore urge the member states to increase the allocation of national budget on health to support health system strengthening and accelerate the efforts towards the attainment of UHC. Develop a skilled workforce in health economics and financing to drive regional growth in health financing and ensure sustainable healthcare funding mechanisms, so that this particular skilled workforce will help us be able to do modeling and identify high impact interventions that we can invest on. And then accelerate implementation of the past resolutions that we have noted that aims to strengthen healthcare systems and address the barriers to accessing primary healthcare. And then the HMC to direct the Secretariat to generate evidence on health financing needs and to prepare for and manage health consequences for climate-related disasters and other sector-wide shocks. And then produce regional annual reports on health financing by the ECSA Health community member states, and actively track progress towards attainment of UHC, as well as provide opportunities for sharing best practices. And then support the member states to build the skilled workforce in health economics so that this can support the member states as needed. Madam Chair, that is the second draft resolution.
Thank you. Are there any comments on the second resolution on health financing to build resilient health systems? I don't see any comments. I guess the honorable members can move for adoption of the resolution and we proceed. Proceed.
Thank you, Madam Chair. If you can project the third resolution, draft resolution. The third draft resolution is on emerging and re-emerging infectious diseases and health emergencies. And we are aware that the ECSA region experiences frequent outbreaks of infectious diseases like cholera, measles, viral hemorrhagic fevers, as well as other even non-disease health emergencies. And despite the ongoing efforts that are there to implement integrated surveillance and response mechanisms. We note that the crucial role that early detection and prompt notification of diseases or outbreaks and health emergencies play in effective management of the infectious diseases and health emergencies. We are appreciating the advancement made in digital health technologies and their potential to significantly improve disease surveillance, early warning systems, and preparedness and response mechanisms. We are recalling a number of resolutions that were made before. Resolution number 10 of the 44th HMC, which spoke to the issue of control of Rift Valley fever, which was a challenge at that particular time. Resolution number 3 of the 62nd HMC on surveillance and control of emerging health conditions. Resolution number 2 of the 65th HMC in 2018 on mitigating the impact of emerging and re-emerging and looking at the aspect of enhancing capacities for surveillance and emergency preparedness. And resolution number 6 of the 69th HMC that spoke to the issue of One Health approach in managing recurrent and recurrent outbreaks in the region. We are recognizing that while preventive and response mechanisms are well established in many countries in the region, enhancement of the detection capabilities remains a critical need. And of course, is informed by some of the joint external evaluation that have been done recently. It shows that there's quite a bit of progress that has been made, but we still have some gaps that we need to address to be able to attain the full capacities for IHR. We are concerned that the gaps in preparedness and response to emerging and re-emerging public health threats still exist, and further investments are needed to build resilient systems that are epidemic ready. And therefore, the HMC urges the member states to accelerate implementation of the previous resolutions, and particularly looking at those that link to emerging and re-emerging infectious diseases and health emergencies. Enhance early detection through integration of event-based surveillance mechanism into the traditional surveillance systems to create a comprehensive and responsive health surveillance network. This will help us in terms of early warning and action in a timely manner. Enhance utilization of digital platforms and mobile applications to allow for quick and easy reporting of health emergencies, and especially by community health workers that are critical to support the health system, and also the public so that they can be able to report and facilitate that early detection in a timely manner. And this speaks particularly to the aspect where event-based surveillance is concerned, as well as the other opportunities that may be available. Invest in resources to support interventions that build resilience for response to health emergencies, including the aspects of infrastructure and supplies. I think one of the observations that came from the discussions was that while we have quite a number of partners supporting in various aspects, the aspects of infrastructure and systems is very few partners are supporting in this regard. And therefore, this is an area where fundraising is required to build strong infrastructure to build resilient systems. Then the issue of cross-border collaborations that came as one of the critical discussions during the discussions that will aim at facilitating inter-country collaboration in preparedness, response, and also surveillance and epidemic intelligence. And the HMC also directs the Secretariat to enhance resource mobilization strategies and foster collaborations with other partners to support the member states to implement the above recommendations, the above resolutions, so that will be corrected, and develop a monitoring and evaluation framework to track progress and report during this next HMC, and also support the member states to implement the above as well as the past resolutions. Madam Chair, I wish to submit.
Thank you, Dr. Martin. Any comments on Resolution 3 on emerging and re-emerging infectious diseases and health emergencies? I don't see any reactions. Uganda?
Thank you, Chair. I just need a small clarification on the directive to the Secretariat. Number 2. These are the draft resolutions which are going through for 73rd. But I want to be clear where it's saying that developing monitoring and evaluation framework and track the past resolutions to be reported during the 75th Harris Ministers Conference. What happens? There is no 74th conference. We are waiting up to 75th because I recall we said it is very pertinent that we should look at these backlog resolutions and get them out of the way to see whether they have been implemented, and if not, why they are not. I just wanted to know the time of presentation of these resolutions, whether at which sitting. Thank you.
Okay, thank you, Honorable Minister. Okay, there's another comment from the DG.
Yes, just to directly respond to the query from the Honorable Minister from Uganda. Usually the next meeting after this one would be the one that the ministers hold just before the World Health Assembly in Geneva. It's a more business style kind of meeting to address the operational issues of the organization. And then the one such as this one would be the subsequent one. So that's why it's in that anticipation that we went for the 75th rather than the 74th.
Thank you, DG.
Our WHO colleague wanted to offer some inputs to strengthen the resolution if it's acceptable to the Honorable Ministers at this stage.
Okay.
Thank you very much, DG, and I think your comment is very, very valid. Normally, when the resolutions are made, and I've seen this for us, even for the regional committee, the monitoring is normally probably 2 years after, so that you allow time for the implementation of the resolution, so that immediately after the next ones, the implementation might have not been done. However, for this resolution, I really wanted us to take cognizance of the fact that they just concluded World Health Assembly endorsed unanimously the amendments to the international health regulations. This is going to have a bearing on member states, because now the member states will need to domesticate those amendments. So I really thought that in the preamble, we should note the recent amendments to the international health regulations, and then craft a resolution on member states trying to implement those amendments within their policies and legal systems, and that the Secretariat, working with WHO, will assist member states to fast track that process. I beg to move.
Thank you for that intervention. I recognize Mauritius.
I have a suggestion to make here. When we are dealing with emerging and re-emerging infectious diseases across subcontinents, the most important issue is that making a prompt diagnosis of a disease. And I would suggest that a point of care testing facilities, procurement can be facilitated through the organization so that we can have those equipment available for a prompt diagnosis. And then that will make things much, much easier for us. Thank you.
Thank you, Mauritius. I just want to know from the honorable members if the suggestion from representative of WHO is accepted. So that we can include it in our resolutions. I don't see any objection to that. So I think WHO will assist the Secretariat in drafting the resolution. Yeah, the amended resolution. Thank you very much. I think we should now move to the next resolution. We adopt the third resolution. I don't see any objection to adoption of the resolution, of the third resolution. We can proceed.
Yeah, thank you very much, Madam Chair, and thank you, honorable ministers, and also the delegates for those two inputs, which we have taken note of and will be adjusted. So the aspect of taking into account the amendments of the IHR and also the aspect of improving diagnostics and all that, and we'll add that to strengthen the actions under that resolution. So with your permission, I'll go to resolution 4, strengthening implementation of national action plans for AMR on AMR. And we are recognizing the significant burden AMR places on economic development, global health, and food security. And we are recognizing the importance of the strong political leadership and governance structures at national, national, regional, and global levels required to sustain cohesive and all-inclusive government response across all sectors using One Health. And I think that is something that was emphasized during the discussion earlier on today. We are noting inadequate financing for sustainable implementation of the interventions within the NAFs. And I think from the projected statistics and graphs, we saw that almost all countries, actually all countries have got NAFs, but in terms of the implementation of those national action plans, they are not implemented to full capacity because of the resourcing and providing the assigning specific funds to that effect. We are underscoring the critical need to establish robust and harmonized AMR surveillance and monitoring systems within the countries and across the region, while reiterating the need for enhanced data governance and sharing mechanisms to accurately track AMR trends and provide evidence-based intervention. We are aware of the commitments that was made during the 72nd World Health Assembly to develop national roadmaps and strengthen health systems to improve water and sanitation services. We are noting the effective infection control, prevention and control is fundamental in preventing the emergence and spread of AMR. And I think we also saw some elements from the earlier presentation. We are recognizing that misuse and overuse of antimicrobials in human health, agriculture, and veterinary sectors are primary drivers of AMR, and the critical role of equitable access to effective antimicrobials and diagnostics in human and animal health is important. And we are appreciating there has been global commitments including the Global Action Plan for 2015, Agenda 2023, as well as other declarations related to AMR. We are recalling previous resolutions, including the second resolution of the 65th HMC, urging member states to develop and or strengthen multi-sectoral national action plans on AMR in line with the Global Action Plan. And I think this is something that has been achieved already with all countries already having their NAFs and also others going to National Action Plan number 2. A number of countries have already developed the second version of NAFs. We are also recognizing Resolution 2 of the 69th HMC that spoke about providing opportunities for achieving WASH global health targets. And we are also noting that the progress in some of the resolutions, especially the implementation aspect, remains suboptimal. And we are aware that these gaps require full and accelerated implementation of the past resolutions. And therefore, the HMC urges the member states to mobilize and dedicate funding to support implementation of the NAFs across human, animal, plant, and environmental sectors, and also ensure the engagement of the private sector players. You will notice that that item added there in blue is something that we picked from the discussion that we are here. It may not be in the print copy because we are also picking your inputs as we are moving along during the previous, the earlier presentation. So we have brought the element of the private sector into the action. We are also urging the member states to establish and or strengthen integrated national surveillance systems to monitor antimicrobial resistance, antimicrobial use, and antimicrobial consumption effectively, ensuring real-time data sharing and collaboration across all sectors. We are also urging the member states to enhance implementation of infection control and prevention and control and biosafety intervention across all sectors, including waste management, and urge for compliance to set standards for national and facility level in terms of the IPC and also healthcare waste management, which is a challenging issue. We are also urging the member states to strengthen the enforcement of regulations and the promotion of best practices to ensure access to quality and effective antimicrobial diagnostics. And based on the discussions again that happened earlier, we have also brought for your consideration the aspect of enhancing the demand side in terms of informing the community so that they can also be key players into this global public health issue. So we have added an element there, enhancing awareness campaigns to ensure community involvement in the AMR control strategies. And if honorable ministers and you could allow, we could probably make this, we could cite that particular innovation that particular countries could consider. But this is brought to you for your consideration. And then the HMC directs the Secretariat to harmonize the strategies for AMR control to strengthen regional collaboration and evidence generation for action, and especially when it comes to regional collaboration, including the multi-sectoral collaboration. And then enhance resource mobilization so that while the countries are also putting aside resources, we also accelerate in terms of looking for resources as part of our mandate to be able to support the countries effectively. And then develop a monitoring framework and track progress of the implementation of the past resolutions and report during the 75th HMC, and also support the countries in the implementation of the above as well as the past resolutions. So, Madam Chair, that's the fourth draft resolution that is proposed for the consideration of the HMC.
Thank you, Dr. Martin. I open the floor for comments on resolution 4. I don't see any comments. Therefore, the resolution is adopted unless there is an objection. We can proceed.
May I?
Yes, I said you can
All right,
proceed.
so thank you. Thank you, Madam Chair, honorable ministers, and distinguished delegates. I would wish now to present the draft resolution 5, reproductive health, maternal, neonatal, child, and adolescent health. In terms of the thematic areas, the sub-themes, there was an element of nutrition to this particular area, and therefore, based on the discussions that ensued, the issue of nutrition became quite an important discussion, and therefore there's a separate resolution on nutrition. So we are aware of the importance of promoting early childhood development and child health and safety. We are cognizant of the inconsistencies in the existing child legislation and suboptimal community involvement in this same. We are concerned with the increased incidences of violence against children and long-term consequences that threaten to undermine the investments in children health and well-being. We are mindful of the problem of violence against children and provision of the suboptimal nurturing care and slow implementation of adolescent and youth sexual and reproductive health strategies. We are appreciative of the efforts that the ECSA-HC member states and its partners have put towards strengthening child protection and child care initiatives. And we are understanding the key role that the ministries of health have in violence against children interventions and prevention and response. And we are determined to accelerate the implementation of the initiatives for promoting early childhood development and addressing violence against children. We are inspired by the upcoming convening of the first global ministerial meeting on prevention of violence against children and the interest of partners to support efforts to sustain the growing momentum towards elimination of violence against children. We are recognizing the critical need for the region to implement programs to address adolescent health. Excuse me. We are recalling the past resolutions, including the third resolution of the 71st Health Ministers Conference, urging member states to advocate for the use of VAC data to inform and drive systems-based in actions. And to that effect, the Secretariat has done some work in terms of landscape analysis in the region, which were shared in some presentations prior. We are also recalling the fourth resolutions of the 52nd HMC directing members to directing or urging member states to accelerate the implementation of the previous resolutions on GBV. We will make a correction on that in terms of directing, and similarly to the other one. The third resolution of the 69 HMC urging the member states to strengthen the implementation of appropriate and comprehensive adolescent health and nutrition programs, and also the during the 71st HMC urging member states to review adolescent health policies so as to facilitate access to health services. We are appreciating the member states' effort in addressing these challenges by adopting policies and guidance issued by the WHO and other bodies, as well as the national policies on ending violence against children, adolescent and youth, and sexual and reproductive health. But we also note that there is need to accelerate implementation. In that regard, the HMC urges the member states to accelerate implementation of the policies and strengthen surveillance system for initiatives to address VAC through deliberate allocation of resources and human, in terms of funding and human capacity. Promote institutionalization, multi-sectoral involvement with defined leadership roles, and increased financing to support implementation of nurturing care framework for early childhood development. Review and streamline child protection laws to ensure harmonization of registration at all levels. Enhance community involvement and partner collaborations on issues of early childhood development and work. Integrate and implement robust knowledge management systems as mechanisms for accelerated implementation of adolescent and youth sexual and reproductive health policies. And commit to regional and global adolescent related commitments and integrate their components into national emergency preparedness and response plans to maintain service continuity. And also contribute to the preparations towards the ministerial conference on VAC that is scheduled for later part of the year in November 2024, and participate appropriately so that we can also add our voice to the same. And then also direct the Secretariat to document and disseminate findings from the global and regional landscape analysis, which I have mentioned that following the last year's directive, we did some landscape analysis and some of the findings we have presented here, and we continue to disseminate. Provide support to the member states to prepare for the global ministerial conference, and the support member states to implement the recommendations, the above resolutions, and also develop monitoring framework and track the progress and report during the next HMC. You will notice the last two directives are coming after each of the resolutions, so that we can be sure to track for each and every one. And this is a recommendation that came from the DJCC that we have adopted. I beg to submit, Madam Chair, the fifth draft resolution.
Thank you very much, Dr. Martin. Page 13, where you are saying to direct the Secretariat to provide support to member states to prepare for the global ministerial. What kind of support are we talking about here?
One of the aspects would be related to, of course, engaging with partners so that maybe we can get some resources to support in terms of participation, and also in terms of generating possession in terms of the discussions that will be going on. So we look forward to maybe to work with the technical experts within the countries so that they can prepare their ministers accordingly for this particular conference, so that the contribution from the member states can also be had during that conference.
Thank you. I open the floor for comments. I recognize Malawi.
Thank you, Chair. It's just a concern because here we're talking about violence against children only. What about women?
What about women? Yes, Martin, you can answer.
I will request one of my experts to say why not women. And I have also had some voice asking why also not men. So maybe we can hear the focus.
Thank you, Madam Chair, for the question. I think we need to recognize that, of course, the area is very broad, but in essence, we are all contributing to the implementation of the global strategy for women, adolescents, and children's health. And one aspect of that is the health, well-being, and safety of children. The particular focus in this particular instance is preventing violence against children. But of course, recognizing that there are many other efforts that we need to put in place to address the other vices that include gender-based violence against women and indeed against men. So it was really just the aspect of the focus of this particular ministerial conference that is coming up. In fact, it happens to be the first global ministerial conference on violence against children. Thank you, Chair. I submit.
And Chair, maybe I could add, as DG is coming, if in the past resolutions, there were also some focus on gender-based violence, as well as other LAMCA interventions, which we are recalling in this resolution.
DG and then Mauritius.
The presenter has actually said, in essence, what I wanted to say, that in the past, the ministers have had occasion to examine and make resolutions on gender-based violence and other forms of intimate partner and domestic violence, which perhaps should be included for tracking. But among the things that happened through those processes were the development of prototype policies on addressing survivors of domestic violence. Yeah, so you have previously addressed the issue, but we could update it and bring it back the next time. Okay.
Thank you, DG. You have the floor, Mauritius. Yes.
Yeah, thank you, Chair. I think we are talking of maternal health, child development, and at the same time, we have been talking about gender balance. So I believe the men component is totally out across the board. For Mauritius, because we are an aging population, average age is 75 years. And we genuinely have a problem of gender-based violence with regard to men. And also the aging population, the ICOP integrated healthcare for the elderly is on our table. So I believe that, of course, Africa is various developmental stage. And this ICOP element, elderly people care, is totally been abducted from the whole scheme. So maybe it was an offside from all of us. And I need to bring it to the table that gender-based violence means everything. It's not only men and only women and children. Please, thank you.
Thank you, Mauritius, for that intervention. Is there any other intervention? I think we have exhausted all our comments. We can now adopt the resolution and move to another one if there is no objection. Resolution adopted.
Thank you, Madam Chair, and thank you, honorable ministers and distinguished delegates for those inputs and comments which have been clarified and some which we take note of. If you could give me the next. Draft resolution 6 is on nutrition for promoting health and development. We are acknowledging that malnutrition in all its forms, including undernutrition, micronutrient deficiencies, overweight, obesity, not only affects people's health and well-being by impacting negatively on human physical and cognitive development, compromising the immune system, increasing susceptibility to communicable and non-communicable diseases, restricting the attainment of human potential, reducing productivity, but also poses as a high burden in the form of negative social and economic consequences to individuals, families, communities, and states. We are mindful that humanitarian crises throughout the world continue to multiply due to the impact of conflict and climate change, as well as other factors. And given this reality, it has become necessary for humanitarian and development actors to work with governments to support approaches to reduce humanitarian need by supporting longer-term systems strengthening, including the aspect of providing food and nutrition support. We are recognizing that nutrition issues go beyond the health sector, hence the need for engagement across sectors, reiterating the need for adoption of evidence-based informed strategies and actions for young children and adolescents to reduce various forms of malnutrition, such as anemia, stunting, overweight, and obesity. We are appreciating the political leadership and collaboration in fight against malnutrition with governments and private sector donors, pledging more than $27 billion at the Tokyo Nutrition for Growth Summit in 2021 to address the global malnutrition hunger crisis. We are recalling past resolutions, second resolutions of the 30th HMC on nutrition as a development issue. We are also recalling resolution 9 of the 48th HMC on improving maternal, newborn, and child health nutrition. And we are also recalling a similar resolution during the 50th HMC, resolution 7, and also resolution 6 of the 52nd HMC, speaking to on the issue of prioritizing nutrition interventions, and also the 56th HMC provided resolution number 2 on innovations for improving quality of LAMCA and nutrition interventions. We are reaffirming the member states' commitment to accelerate the progress towards the actions from the International Conference of Nutrition and the UN Nutrition Commitments and Nutrition for Growth. We are noting that progress has been made in the member states on developing and implementing nutrition programs and plans of action. However, despite these efforts, we still have quite a huge number of children below 5 that face various forms of malnutrition. And further, there has been modest and uneven progress in reducing malnutrition with limited attention and inadequate budget allocation. So we are now, the HMC now therefore urges the member states to accelerate the implementation of those previous resolutions that spoke to this particular issue, to domesticate, operationalize, and track the Nutrition for Growth Commitment for Africa to align and harmonize actions across sectors and stakeholders, strengthen multi-sectoral collaboration, including the engagement of civil society organizations to support on advocacy and investment for nutrition, and adopt innovative ways to embrace flexible programming in addressing nutrition and food crisis, including humanitarian situations such as triple nexus model, humanitarian development and peace. The HMC also directs the Secretariat to facilitate the development of regional nutrition accountability scorecard that focuses on key selected indicators following a continuum of care, support the member states to implement the Nutrition for Growth initiatives, and facilitate South-to-South knowledge exchange, evidence generation, and collaboration among the member states on lessons for nutrition, such as triple nexus model, and support integration of targeted adolescent nutrition initiatives into the existing sexual and reproductive health services that are gender inclusive at all levels, and develop monitoring and evaluation framework and track the progress of the implementation of the past resolutions and the report during the 75th HMC, and also support the member states to implement the above and the past resolutions that have not specifically been mentioned. Thank you, Madam Chair. I beg to submit for the HMC consideration.
Thank you, Dr. Martin. Honorable Ministers, comments on Resolution 6. I don't see any comments. Resolution is adopted unless there are any objections. We can proceed.
With your permission, Madam Chair, I can proceed to draft resolution number 7. Tim, if you could give me number 7. Non-communicable diseases, injuries, mental health, and substance use. We are acknowledging that non-communicable diseases such as diabetes, hypertension, cancer, chronic respiratory diseases, as well as injuries, are among the leading causes of morbidity and mortality in the region and globally. We are concerned with the increasing rate of substance use, leading to high rates of mental disorders and subsequently causing deaths. And there's an example of some statistics there in terms of the high number of deaths globally. And as a region, we are not spared. We are noting the efforts that have been made by the member states in addressing non-communicable diseases, injuries, mental health disorders, and substance use. We are recalling the third resolution of the 65th Health Ministers Conference on multi-sectoral responses to non-communicable diseases, urging member states to develop and accelerate implementation of multi-sectoral NCD plans and strategies. We are also recalling resolution 5 of the 69th HMC that urged member states to develop and strengthen mental health policies. We are noting whereas the progress has been made towards developing and implementing programs and plans for action for preventing NCDs, injuries, substance use, and mental health, more needs to be done. And now the HMC is urging the member states to foster coordinated response at the multi-sectoral level for prevention and control. If you could move the, yes, thank you. Foster coordinated response at the multi-sectoral level for prevention and control of and management of NCDs, including NCD actions as a key performance indicator. Prioritize mental health and adopt a holistic approach in addressing risk factors and drivers of mental health. And we'll also incorporate the substance use drivers of mental health disorders and substance use. So we will make sure that we incorporate that as in the action. And the HMC also directs the Secretariat to document NCD, mental health, substance use, and policies, guidelines, protocols, and facilitate knowledge management and sharing across the countries, and then develop a monitoring framework to track progress and report during the 75th HMC for these particular actions and also for the past resolutions. And we also support the member states to track the implementation of the past NCDs, injuries, mental health, and substance use resolutions. Madam Chair, and I would wish to submit for HMC's consideration the 7th draft resolution.
Thank you, Dr. Martin. Are there any comments, Mauritius?
If you could bring back the resolution.
Thank you, Chair. Two small comments. I think, can you show me the slide there? Because I can see on my paper, you have only two urging statement where I suggest the statement of substance abuse has to be included on instead of 1 and 2, the third one has to be included separately, so that only you can give a directive below downstairs.
Okay.
Right, so that's missing. And also in regard to NCD issues, I would suggest to give directive to the Secretariat to classify those countries who are falling under these categories, so that easier to focus on a common ground of working together. But not, of course, we have many issues that are cross-cutting, but with NCDs, not every country is on those lines. So we need to classify them. Thank you.
Okay.
Your comments are noted and will be taken care of. Any other comments? I don't see any other comments. We therefore adopt resolution 7 and move to another resolution.
The team, you can please keep the resolutions on. Let's just keep to this. Draft resolution number 8, mitigating the effects of climate change on health. We have provided a small preamble there, defining climate change. But we are also noting that the climate change is not just an environmental issue, but also a significant threat to public health, and its impacts on health are complex, multifaceted, ranging from the direct effects such as heat-related illnesses to indirect consequences such as change of disease patterns, food security, and so on and so forth. We are cognizant of the far-reaching consequences for the ecosystems, economies, and human health as a result of direct effects on health through various pathways, including extreme weather events, heat waves, air pollution, and changes in disease patterns. We are concerned that in the ECSA region, we have already experienced the challenges related to climate change and health. And this is as a result of frequent droughts, floods, cyclones, heat waves, among others, which contribute to food and water insecurity, increased vector-borne diseases, heightened malnutrition rate, among other health effects. We are mindful that there is inadequate data documenting the effects and impacts of climate change in our countries around here, leading to low levels of awareness and significant response to build resilient systems to mitigate. We are acknowledging global and regional resolutions and commitments in climatic change and health, including, among others, those resolutions made at the World Health Assembly, especially one adopted in 2008 that urged member states to take action to protect health and climate, including strengthening surveillance and response systems. We are also recognizing the Libreville Declaration on Health and Environment in Africa, the Paris Agreement adopted in 2015. We are also taking note of the Sustainable Development Goals, and especially SDG 13, that calls for urgent action to combat climate change and its impacts. We are also recognizing Africa Union Agenda 2063, and particularly the emphasis on climate resilience and sustainable development to improve health outcomes on the continent. We are recognizing that mitigating the effects of climate and health requires concerted efforts and regional collaboration and comprehensive policy is needed. We are aware that there has not been a specific resolution passed in the past by the ECSA Health Community member states on this particular subject, and that it is important that we domesticate actions that contribute to the problem. The HMC therefore urges the member states to, number one, invest in research to better understand the links between climate change and health outcomes and generate evidence to inform regional action. This is informed by the limited data that is available, especially on this part of the continent. Enhance surveillance and early warning system by investing in surveillance systems to detect and monitor climate-sensitive diseases to provide timely information for preparedness. Establish mechanisms for coordination between human, animal, environment, agriculture, and other related sectors to create integrated climate and health policies. Employ a whole of government approach in engaging local communities in the development and implementation of climate adaptation strategies, ensuring that their knowledge and needs are integrated in the policy decisions. Build a healthy circular economy in food, waste, urban ecosystems by defining and planning innovative and incentive-based programs that reclaim urban spaces for urban agriculture. Establish or strengthen and reduce, recycle, and reuse waste management systems through community, private, and state actor partnerships to improve access to quality health. Harmonize local and national laws, policies, and regulations by integrating and institutionalizing relevant evidence, including health impact assessments, to strengthen the systems. Establish or engage regional and national research and development and training or academic center to generate new knowledge, support technology transfer, and strengthen integration of the existing knowledge and technology focused on innovative, relevant, and climate responsive approaches. The HMC also directs the Secretariat to support the member states to develop metrics and implement health impact assessments to monitor the effectiveness of climate and health interventions and regularly report on progress. Establish regional training and capacity building programs that speak to this particular agenda, and develop monitoring and evaluation framework to track progress and report during the next HMC, and also support the member states to implement the above as well as the past resolutions. Madam Chair, that is the draft resolution 8, and I would wish to submit for consideration by the HMC.
Thank you, Dr. Martin. Honorable Ministers, comments on Resolution 8. I don't see any comments. I therefore think that the resolution is adopted and we proceed.
Thank you, Madam Chair. And thank you very much, honorable ministers and distinguished delegates for adopting that resolution. I will now present draft resolution 9, technology and innovations in health. We are cognizant that innovation and technology play a pivotal role in every aspect of health system, including generation of medical records, digital education, learning, diagnostics, surveillance, and many other areas. We are recognizing other commitments, including the resolution by the World Health Assembly on health and technology, which urged the member states to expand expertise in the field of health technologies, in particular the medical devices, and for WHO to take actions to support countries. And also another resolution then on health intervention and technology assessment in support of HMC. We are recalling one resolution that was made by the Health Ministers Conference during the 54th meeting in 2011 on innovative use of health information technology and system, and urging member states to adapt and validate e-health technologies to support in terms of health systems improvement and service delivery. We are recognizing that if these innovations and technologies are implemented effectively, they offer substantial potential for providing, of course, more accurate diagnosis, surveillance, monitoring of care, and so on and so forth. And we are appreciating that the technological innovations are already in use by the member states, including mobile health applications for various purposes. And we are acknowledging that the member states remain underserved, and especially where it comes to the relevant infrastructure to support the digital health expansion. And we are underscoring the need to use a digital health solution to complement the existing models, other models of service delivery. And therefore, the HMC is urging the member states to adapt and leverage on technologies to improve access to health care services, particularly to the vulnerable and hard to reach communities, mobilize resources to enhance digital infrastructure to be able to support the deployment and scaling up of health technologies across the region. The issue of artificial intelligence and machine learning to enhance diagnostic services, treatment, and disease prediction, as well as surveillance and prevention approaches, and enhance data sharing frameworks between member states to ensure effective exchange of health data, thereby promoting disease surveillance and improved treatment continuity and public health outcomes. And this is where the issue of cross-border collaboration comes in. Of course, taking into account the sensitivities related to data sharing. Therefore, this HMC direct the secretaries to establish a regional platform to support coordination and sharing of best and promising practices, and also support the member states to track the implementation of the past resolutions and report during the 75th HMC. And we also include the action to support member states to support on the actions that have been indicated above. Madam Chair, I beg to submit.
Okay, thank you, Dr. Martin. Honorable Ministers, your comments and reactions on Resolution 9. Mauritius.
Thank you, Chair. My suggestion is harnessing technology to deliver primary healthcare services. And I suggest that teleconsultation be included in this concept node so that we can reach the far-fetched people to deliver better services. Thank you.
Thank you, Mauritius. Your comment is noted. Any other reactions? If not, we adopt the resolution and proceed to Resolution 10.
Thank you, Madam Chair, Chair of HMC, and honorable ministers. I will now request to present resolution 10 on sustaining interventions for TB in the mining sector. We are aware that the ECSA region is considered a high burden area for TB with an elevated high burden in 9 of the Southern Africa countries, falling among the 30 high burden countries. And this is not just for the Southern Africa, I think also for the whole of ECSA region. This also covers the other countries in the ECSA region. We are mindful of low domestic funding to TB by the member states to implement critical high impact interventions. We are recognizing or noting the implementation of 2012 SADC Declaration on TB in the mines and the Code of Conduct that guides on the implementation. We are recognizing the notable progress that has been made towards eliminating TB in the mining sector and also generally, although there are still gaps and especially related to access to diagnostic service for TB and occupational lung diseases. And I think a previous presentation by Dr. Lungu demonstrated the progress that has been made, but also sharing some of the challenges and issues that we need to speak to. We are realizing the suboptimal integration of occupational health services into the public health systems across the region. We are aware of the goodwill and commitment from the member states in the region to tackle challenges posed by TB in the mining sector. We are cognizant of the fact that artisanal and small-scale mining activities are expanding and therefore potentially creating a huge burden of TB and occupational lung diseases. We are noting that improved health status for the underserved population and achieving health-related SDGs requires cooperation across the region through excuse me. I wish to get a glass of water. So we are noting that improved health status of the underserved population and achieving health-related SDGs requires cooperation across the region through a common regional approach. And we are also further noting that catalytic investment that supported the establishment of some of these critical one-stop occupational health centers through one of the partners support and brought services closer to the targeted population. These centers were already in existence, but we note that due to funding, most of these are no longer operational. And therefore, the HMC urges the member states to support TB cross-border collaborative initiatives by fast-tracking the implementation and the use of cross-border referral systems for TB patients. This is to foster the issue of cross-border TB management to the entire ECSA region and beyond. There was a comment, if you notice, this, you go back to the first one, Honorable Ministers, there was a comment that was made by Uganda in terms of the situation is not just in the Southern Africa, but also across other regions. And so we are looking in terms of having this going beyond even the ECSA region, because diseases no border. So we have made that adjustment from the discussion that came earlier. Increased funding for TB control, including drug-resistant TB. There was a comment again that came from the floor in relation to also having a mention on drug-resistant TB, which is a problem in this region. Revamp, expand, and sustain the occupational health service centers across all member states. As I mentioned, these were critical investments that were very, very useful, that would need to be sustained. And therefore, this is calling for support to be able to revamp these occupational health service centers. Employ a human-based rights approach in the TB response by implementing the developed action plans and investing in community-led monitoring to address TB and occupational health services. There were action plans that were developed and countries supported to adopt, and therefore this request is to support the implementation of those action plans. Encourage the Global Fund and other international donor organizations, and we have also added the private sector based on the previous comments that came from the floor after the presentation, to earmark funding to support regional approach and collaboration in aiding TB in the mining sector and to prevent regression in the milestones already achieved and accelerate the response towards eliminating TB. You will notice two other items there that we would wish to bring to your attention, and this came from the discussion that came earlier. In terms of scaling up measures for detection of TB in children, among others, use of as tool to detect the TB because of the challenges that are there in terms of detecting pediatric TB. We will clean up the wording, but this came from the discussions earlier. Strengthen capacities for leprosy. I think something this was raised in terms of we've been focusing on TB, but it's also an emerging problem of leprosy, and these are interrelated. We have added an action there so that we can also take action in terms of addressing leprosy in addition to TB. And we should also mention that some action or support had already commenced through one of the previous initiatives, with ECSA supporting some countries to revamp the leprosy diagnosis in the countries. And we worked with Malawi, we worked with Zambia as well. And this particular initiative, we found that the experts started picking leprosy cases, which would already have been missed. And we have some data that we could show to that effect. So this is a critical issue that we need to consider. So direct the Secretariat to disseminate and share best practices within the region on ending TB in the mines. Establish a regional community of practice for community-led monitoring experts, so that it can bring the aspect of the community into the interventions, and support member states to implement the resolutions. And we also bring the aspect of tracking and monitoring the resolutions and presenting during the 75th HMC. Madam Chair, I request to submit for consideration, for discussion and consideration.
Thank you, Dr. Martin. Are there any comments? I see Tanzania and then Malawi.
Thank you, Chair. Through my head of delegation, I would like to add, first, I would like to thank the Secretariat and the consultative committee for the resolutions that are brought forward. One thing that we would like to add, as in Tanzania, cognizant of the fact that TB in the mining sector is common, but we also have other, like it has been said, occupational lung diseases. It's common that these patients, they're cured of TB, but they have sequelae of TB, which is really not addressed. And I think it's not coming out clearly here, post-TB lung disease, particularly in this group. And so in Tanzania, as in Tanzania, would like to us to consider that in the resolution. A second, Madam Chair, through my head of delegation as well, would like to ask the ministers to reconsider the last two resolutions that were added to the member states, and the number 5 and 6, if you will please display them on the board. These read 6 and 7, scale up measures for detection of TB in children, among other use of stool. And the other is strengthening capacities for leprosy management. Now, Madam Chair, as much as we don't have any problems with these, but they really do not come out from the mining sector. And so they seem to be off the TB in the mining sector, unless we want to rephrase the resolution. Thank you. This is just for your consideration.
Thank you, Tanzania. We note your comments. Malawi.
Thank you, Chair. It's just maybe it's a typo error on in our documents showing resolution number 9, but this is resolution number 10. Maybe it's just a typo error. Just have to change it.
Yes.
Thank you.
Okay. You can address Tanzania's concern.
Yeah, thank you, Madam Chair, and thank you, Honorable Ministers. Honorable Deputy Minister for Malawi, we've taken note of the typo, so we'll correct that. That's number 10. In terms of the added actions. I think the discussions came, of course, from the presentation that was made by Dr. Lungu. It highlighted the challenges that are there in terms of addressing pediatric TB. And even in the mining sector, we still have situations of pediatric TB because there are certain cadres, and especially in artisanal mining activities, where you still find mothers working with their children and so on, in addition to the general aspect of pediatric TB. So, and I think this discussion came from the presentation earlier, and we thought maybe we capture the spirit of the health ministers as they made submission, so that we don't recognize the inputs that they made earlier in the discussion. So that's why we had captured this, but we would wish to be guided. The second aspect, I think it was the interlinkage of TB, leprosy, occupational lung diseases, and so on. So if we don't put some interventions or actions, then of course it will, this forgotten disease will remain forgotten, will not be able to detect, and will not be able to put the actions that are needed. And as we have indicated, this issue had been picked up in previous interactions with the countries, and with the data that we've gotten after training and revamping diagnosis for leprosy. Countries started picking leprosy cases. So it's actually there. And if we don't take action, then this will remain a problem that is hidden. We wish to be guided because this came from the honorable
Let me
ministers
give,
earlier.
Malawi
We
the
are happy
floor.
to consider.
Uganda. I think Uganda wants to say something.
Yeah.
Yes, Honorable Minister.
Thank you so much, Chair. Chair, I just want to associate myself and affirm the position that the presenter of the resolution, especially on the pediatric TB. The issue came out from my presentation, and I vividly recall that the presenter came here and put the record right in reference to the status at the World Health Organization. And since now we are having resolution towards the action plan, and I think it is better that is actionable and considered. Again, when we say the relationship, the interlinkage of TB and leprosy, we all understand that this is the area where leprosy is not really being considered. And the rate is at a high increase, and it is our attention that we should also take action to ensure that we address it in our member states. So I highly support that the two must remain there. I don't see what we need to rephrase. They are very clear and actionable points. I thank you.
Thank you, Honorable Minister from Uganda. Tanzania, does this answer your concerns? Okay.
It's just an observation.
Okay.
Can't go with it.
Okay, thank you. Do we adopt the resolution? Or are there any other concerns? If there is no objection, the resolution is adopted. And I think you can take resolution 11 and 12. I don't think there are
Together.
any issues there. Here.
Mm. If you could give me 11. Technical team.
Can continue.
Yes, draft resolution 11 and 12 are speaking to express appreciation to the partners and also to the government. And I will now give us the draft resolution 11, which expresses gratitude to partners of the ECSA health community. We are acknowledging the contribution of the partners to the gains in the health sector in the region through the support that is given directly to the member states, as well as the collaboration that we have with the various partners. We are appreciating the partners' commitment in strengthening health systems in the region through provision of technical and financial support. We are reiterating the appreciation of the HMC for the continued support from partners to the member states and also to the Secretariat towards the implementation of the resolutions of the health ministers' conferences, the various conferences, as well as other regional and national health programs. Now, therefore, the HMC expresses its profound gratitude to all partners for their support to the health sector in the region and renews its commitment to continued collaboration and genuine partnership in the implementation of agreed projects and programs of work with the various partners, recommitting to the strengthening of coordination of the partners at regional and country level in the spirit of innovation and mutual accountability to achieve better health outcomes of the people in the region. Madam Chair, that is draft resolution 11. I will proceed to give you resolution 12, expression of gratitude to the government and the people of the United Republic of Tanzania. We are humbled by the readiness of the government of the United Republic of Tanzania through the Ministry of Health to host the 73rd Health Ministers Conference. We are recognizing the excellent planning and preparation of this 73rd Health Ministers Conference, and we are appreciative of the warm hospitality and generosity extended by the government and the people of the United Republic of Tanzania to the delegations of the ECSA health community member states, partners, members of the Secretariat, and all participants of the 73rd Health Ministers Conference. And now therefore expresses profound gratitude to the government and the people of the United Republic of Tanzania for hosting the 73rd Health Ministers Conference, and reaffirm commitment with renewed vigor and focus on innovation and accountability through multi-sectoral collaboration to achieve better health outcomes for the people in the region. Madam Chair, I beg to submit. There are a few corrections I'll make there, which we have taken note of.
Thank you very much, Martin. I think we should give him a round of applause. We have in principle adopted the draft report. I think later on in the day we'll get the final report after the remaining topics that we had approved in principle. Thank you very much. I'll hand over to the Uganda.
Thank you, Honorable Chair, and I want to thank you for chairing this session and the presenter. It's my humble request that as the ministers, we move in a procedural manner to adopt the drafts by somebody moving and somebody seconding, and that is it. So if it causes no harm, I wish to move that the resolutions that have been presented to us at this sitting with amendments and observations and the minister's inputs be adopted. I beg to move.
Okay. Oh. Mauritius is seconding.
Thank you, Chair. Mauritius, we second the proposal from our colleague there. Thank you.
The resolutions, the draft resolutions of the 73rd Health Ministers Conference are hereby adopted by the HMC. Thank you.
Thank you very much, Madam Chairperson, honorable ministers, distinguished delegates, ladies and gentlemen. Apology for the time that we have had, but I think we know how important this was, and I appreciate how far we have gone so far. For now, we'll have a short break for lunch, and then, short break for lunch, and then we'll come back and finish the little thing that we are remained with. Enjoy the rest of the day. Thank you very much. We'll be here after like 45 minutes to 1 hour. Would appreciate it. Thank you.
And also the information where the impact of this information will be seen clearly. Therefore, the project on the health emergency preparedness, response, and resilience will be able to really continue with this partnership, and ECSA, part of the organization, also implementing this project. Therefore, we are expecting you also to participate actively into activities of the Greater Honor Africa Climate Outlook, which will be done every 3 months, 3 times per year. Then again, also that project will be able to contribute into filling the gaps in terms of getting climate, very clear picture on the climate change nexus on the health, and also predefine anticipatory action, which can be taken based on the current risk and also what's going to be anticipated in the future, where now we're able to monitor or create the vulnerability maps and also the risk profile for all members. And that one also will be enhancing the spirit of engagement and also partnership between all stakeholders. Therefore, for us able to take really a very serious action, it is very, very important for us to talk about the comprehensive strategies, which actually including the infrastructure, not just only climate producers, and also we able to enhance the disease surveillance and also respond through working together, and also the spirit of collaboration between the government, all organizations, whether governmental, non-governmental, and also international or regional partners. They are very important for us able to.
Yeah, okay. Thank you so much, Dr. Paulino, for those very elaborate presentations. So if you can bring up the slides, we just have like 3 slides, essentially to kind of run through some of the current initiatives that we have tried to basically come up with in collaboration with ECSA to mitigate the impact of climate on health. So, and of course, we are doing this through the support of the current effort is actually through the support of World Bank, and it's through a project called Health Emergency Preparedness, Response and Resilience through a multi-phased program approach where countries join the MPA, this project, through a phased approach. So I'll try to be as brief as possible so that just to kind of bring you up to speed some of the regional initiatives that are currently ongoing. And of course, so as I've said again, we IGAD in collaboration with ECSA has kind of come up with an approach to address the impact of climate on health. So essentially, among the proposals include using an integrated framework that addresses climate health nexus, essentially with a view to ensuring adaptation and building resilience and sustainability of these initiatives. And then, of course, enhancing multi-sectoral approach to address the effect of climate change, of course, within the region. And then essentially, this project is focused towards the supporting the Africa region. These are the countries of the east and the southern part of the African continent. So essentially, IGAD and ECSA will leverage on a number of comparative advantages and of course, institutional strength to kind of, push this agenda. And of course, this includes leveraging on the institutional multi-sectoral capacity, and of course, leveraging on the convening mandate of the two institutions, and also institutional regional framework, as well as utilizing regional networks. Next slide. Next. Yeah, so some of the specific regional interventions that we've come up with to address the effects of climate change essentially includes, of course, which is again supported through the World Bank funded project called Health Emergency Preparedness, Response and Resilience, and of course in the Africa region. And maybe just to give you a small background of this project is implemented within in a multi-phased approach. In the first phase, we have 3 countries which have been, which are currently implementing, and of course this includes Ethiopia, Kenya, and Sao Tome, and subsequently other countries will come on board, and this includes Burundi, DRC, and Rwanda. Then Malawi and Zambia will be coming in shortly, I think probably in the next couple of months. So, and of course, again, as we've said, this is a multi-phased kind of program where countries readily and voluntarily participate in this project, of course, through engagement of World Bank, and of course, after meeting certain criteria. And of course, the package includes grant or loan. So in the next slide. So in terms of, just to kind of give you a quick heads up on some of the specific regional interventions that are focused on, addressing climate within these projects. Essentially, they include integration of health-related climate-sensitive conditions into the East African Hazard Watch. So this platform or initiative is actually currently being implemented by IGAD, the Climate Center, the Climate Center under IGAD. And then another one of the other initiative is development of a health risk profile. So we plan to kind of develop our, health risk profile for major diseases within the Africa region. And this, of course, are the Eastern and the Southern African countries. And of course, with a view to, develop or enhance, address vulnerability and also build coping capacity of this population. And of course, again, building resilience of people and systems within this region. So again, we are looking at, enhancing organizational or cross-sectoral seasonal advisories on climate outlooks and health on events within the participating countries. Again, we are also developing this. We'll be developing this through the IGAD Climate Center to kind of have a climate outlook that provides climatic predictions through the precision and modeling approaches that are used by the IGAD Center. And of course, again, we'll be leveraging so much on the existing platform that is the Greater Horn of Africa Climate Outlook Forum, as well as also enhancing community of practice for climate health. So this is an initiative that we're also coming up with. We'll have we'll try to ensure we have, we try to enhance the climate health interface by developing a, community of practice that brings together the climate experts as well as the health experts with a view to addressing the climate impact within the region. So we, within the initiative, we are also focused to address some of the key research questions that, kind of affect the region within the climate and health nexus. So we'll kind of engage the countries to kind of come up with a research agenda on this space, essentially covering the climate health impact in the region. So basically, this is essentially in brief This is the kind of specific interventions. It's kind of a broad-based interventions that we have kind of developed. But again, of course, it covers different and a number of issues, some of the specific issues, of course. And of course, again, it's not really cast on stone. Through the COP or the community of practice, we'll be refining some of these interventions to be more granular. And of course, in consultation with the participating countries or the countries within the Africa region that are participating in this project. Many thanks for listening, and back to the Honorable Minister for any questions or clarification. Thank you.
Thank you very much for that presentation. I'll now open the floor for discussions, comments, inputs. I recognize Honorable Minister from Malawi.
Thank you, Honorable Chair. Honorable Ministers, distinguished ladies and gentlemen. Honorable Chair, first of all, let me thank the presenter for the good presentation. And let me also thank you for giving me this opportunity to make a statement on climate change and health. As a country and the Ministry of Health, we are deeply concerned about the potential health risks associated with climate change and the need for urgent action to address this pressing challenge. Madam Chair, we all know that climate change is a major threat to public health with the potential to worsen existing health problems and create new ones. Rising temperatures, changing rainfall patterns, and more frequently, extreme weather events can lead to a wide range of health issues, including heat-related illnesses, vector-borne diseases, malnutrition, and mental health problems. In Malawi, like many other countries, we are also seeing the effects of climate change on our population, particularly in rural and vulnerable communities. We have witnessed increased cases of malaria, cholera, and malnutrition as a result of changing weather patterns and environmental degradation. Recently, Honorable Chair, we also had floods in some parts of the country. And as Malawi, we are therefore happy that as countries in ECSA region with support from our partners, we are all ready to take a decisive action to protect the health and well-being of our people in the face of climate change. Malawi, through the Ministry of Health, signed a commitment letter during COP26 held in Glasgow, Scotland, and we are committed to implementing the following initiatives to mitigate the effects of climate change. 1, building resilient health systems, which is adaptation. 2, building a sustainable low-carbon health system, mitigation. The ministry also had identified priorities on climate change and human health that require climate health financing support from potential partners, stakeholders, and donor agencies in the following areas. 1, conducting a comprehensive climate change and health vulnerability assessment at population and healthcare facility level. Finalizing a health national adaptation plan, integrating health in the national determined contributions, assessing climate finance for health, working towards achieving net zero emission in the health system, assessing baseline greenhouse gases emission on the health system and supply chain, developing an action plan for a sustainable low-carbon health system, establishing a climate-informed health surveillance and early warning system, interventions for climate resilient and environmentally sustainable healthcare facilities, climate change and health communication strategy and advocacy, conducting research-related climate and health, and building expertise in human resource for health on climate and health. Honorable Chairperson, Malawi is ready to implement activities on these priority areas, but we need financial resources from partners to facilitate implementation of these activities. The government of Malawi is also committed to making funds available for climate change and health. The change is that the funds we have are not enough, so we therefore need that support from our partners. Thank you, Madam Chair.
Thank you very much, Malawi, for those remarks. Is there any other member state? Oh, Uganda.
Thank you, Chair. We also want to applaud the presentations and take note that health adaptation and building a resilient health system is not an option, but is a must for all our health systems. We also know that the health systems account for limited greenhouse gases emission, which is almost like about 5%, but we must promote clean energy sources and medical practices that reduce greenhouse gases emission, aiming to meet at a net at zero. I want to conclude by saying that climate change is a well-known cross-cutting phenomenon that affects all countries and all sectors. So as health, we need to be able to see how do we work with other sectors so that this reality, we will call for close collaborations, which are, as has been suggested, between countries and sectors and all actors on national and regional and global level in order to effectively respond to this challenge. Thank you, Chair.
Thank you. See no more flags. I hope we are done with this subject. Can we give our presenters a round of applause? I recognize Mauritius. It's okay.
Thank you, Chair. Mauritius being a very small island developing state with barely 1.2 million population, we are a country which is severely affected by this climate change. And I suppose working together will be in everybody's interest to at least help us to better cope with it. Thank you.
Thank you, Mauritius.
Thank you, Madam Chairperson. And I thank you for the presentation from UGET. Allow me now to welcome on the stage Dr. Andrew Silmans, who will be presenting, will give us the next presentation. Dr. Andrew, please.
Thank you very much, Honorable Chair, for the opportunity. In our deliberations over the last couple of days, we did make reference to the fact that there is an upcoming global ministerial conference on ending violence against children. And the emphasis was that in as much as we are aware that most efforts that are aimed at preventing violence against children in the countries are led by ministries of social welfare. As ministries of health, we do have a contribution that we can make to that debate because it does relate to the health, well-being, and the safety of the children. So this presentation is really aimed at making this information available to our honorable ministers with the hope that they will also spearhead efforts to contribute to this discussion in their respective countries. So the first global ministerial conference on ending violence against children is coming up later this year. For the health ministers in the ECSA health community, we have a little background to this discussion. And this is emanating from the discussions of the 71st ECSA Health Ministers Conference held in February last year in Maseru, at which the health ministers, informed by the recent regional studies that have highlighted the high prevalence of violence against children in the region, did pass a resolution to the effect that member states were urged to advocate for the use of data to inform their various actions in the countries. So we are building up on that and would like to encourage that the member states also prepare adequately for the upcoming conference. The conference is to be held in Bogota, Colombia, from the 7th to the 8th of November, 2024. And it will be co-hosted by the government of Colombia and the government of Sweden, alongside the UN family, particularly WHO, UNICEF, and the UN Secretary General Special Representative on ending violence against children. And as I hinted, there will be delegations coming from the countries, which will be multi-sectoral in nature. But we want to underscore the fact that the ministries of health would need to be part of this discussion. The ministerial conference will aim to achieve a number of objectives, which include the following: that there will be bold new commitments for preventing and ending violence against children, as well as renewed collective child protection, and also beginning a discussion or a movement for the youth in terms of their involvement in child violence prevention. It is also hoped that there will be an intergovernmentally consulted political declaration at the end of that engagement, as well as providing a platform for survivors to share their expertise and experience. Nations that will be going to this conference will be supported, a number of them will be supported to prepare in the process that's called the National Preparatory Sessions. So this will involve an official invitation to the ministerial conference, but also countries beginning their discussions way in advance as to what they would want to see at the end of those particular discussions that will be held during the conference. Chair, this was essentially the information that we thought we needed to bring to the attention of the honorable ministers, and do urge and request that they be part of this discussion as they get back to their respective countries. Thank you very much, Chair. I submit.
Thank you for the information. I don't know if there are any questions or clarifications on the upcoming ministerial conference, or everything is clear. I don't see any questions. I think everything is clear. Program Director. May proceed.
Thank you, Madam Chairperson. Allow me for now to welcome Madam Stella, Dr. Stella Tungu, to present on building skilled human resources for health towards attainment of universal health coverage in the ECSA-HC region. Welcome, Dr. Stella.
Protocol observed. Ladies and gentlemen, good afternoon. It becomes so difficult to present something that has already been adopted by the ministers. I will try to limit myself to the action areas that have already been incorporated in the minister's report. I'll take us back to the 25th and 26th Health Ministers Conference that made resolutions to establish colleges in order to address the gaps that were identified then. And they are still the impending gaps we are facing today. Majorly, there were the short limitations in the health specialists in the region, the brain drain and the cost of training the health workers that wanted to advance in specialty training. The ECSA health community, in response to the directive by the health ministers, went ahead to establish the colleges. Today, we are making 11 colleges. As of yesterday, were only 9. And I want to thank the health ministers for that decision that they've taken. The colleges, the 9 colleges that we are talking about, excluding the 2 that have been approved today, cover a very wide geographical spread. We are undertaking our operations of training in over 21 countries in Africa. ECSA has 9 countries, but ECSA, through its programs, projects, and colleges, goes beyond 9. And today, most colleges are in over 21, a few are below 18. We serve a population of about 500 million people, much as we are talking of the shortage of health workforce, but that's the combined population of 21 plus countries in the region. I would like to report to you, honorable ministers, that ECSA has achieved greatly in terms of addressing the gap that you saw those years back. And today, as colleges, we are proud to say that we have graduated over 1,005 specialists. We occupy or are in 142 plus accredited sites where we undertake our training. We have 5,865 fellows and members. We do have a total of 1,460 trainers, and these are in the training hospitals. We have 216 accredited sites altogether as 9 colleges. And we have master trainers, 141. So the master trainers take the trainees and trainers through other courses like leadership, critical non-clinical training, teamwork, on-bed communication. So those are the other areas where we take our trainees through. We do not want to concentrate on the standard training. We know and believe that for us to achieve quality care, it's beyond the hospital clinical training. There are other aspects that contribute to quality and patient outcomes. Currently, we stand at 88.8% retention rate in the region, but in some countries, they're at 93%. That does not mean that those that are retained are employed. There are those that are within, but not fully employed. So beyond this, these are the key achievements. The retention rate is high, which was one of the calls to curb down brain drain. The workforce has increased. The training sites have been assessed, accredited, and availability of other training opportunities like scholarships, research grants, travel grants, post-fellowship programs, and exchange programs. I had a discussion today with the Director of Services from the Ministry of Health, Mauritius, and he would like to look into the exchange program so that we can have an exchange of trainees within our region. So I should say that this meeting has really helped us in networking, but also in trying to harmonize and see how we can help each other in the region. The slide you're looking at today, the first day I reported that we have 550 operations undertaken. That is a slide of Feb 2024. But as I speak, the surgeons of the College of Surgeons, or COSEXA, have currently undertaken 550 surgical procedures in different cases of surgery. The action areas that are already in the report are the 2 new colleges. I'll not delve into them. They've already been adopted. But just to mention that they both went through the normal procedures, through the DG, to the Senate, to the committee that reviewed the eligibility, and now to you, and thankfully you have approved them. Another action area that we have in the report that you've already adopted is recognition, which is a challenge in the region. We are fully recognized in some countries, and in other countries, the specialists are not accredited or recognized fully. You find in some countries the Medical Council and the Higher Council of Education. In another country, it's only the Medical Council. So when our trainees go through this training rigorously, at the end of the day, they are not recognized by either the Higher Council or the Ministry of Education. I'm glad that this has been adopted as one of the recommendations that we should push to make sure that the operationalization of the CHS is facilitated to have the standards of accreditation and licensing of certificates of our trainees undertaken in the region. Gender mainstreaming, as you'll see on that slide, it has 2 key areas. One is the gaps in training, especially support due to the cost, and also the number of females that we enroll each year. As you'll see, there are only 62 out of 288 in 2020, 84 out of 221, out of 301 in 2021, 98 females enrolled out of 373 in 2022, and 100 out of 349 in 2023. Clearly, the females are still lagging behind. So the gender mainstreaming, not only in training, but other activities of ECSA is something that we have to work on. The scholarship, the first day I reported that we always drop half of the number of applicants. Not all have financial challenges. There are those that apply and they're not eligible, but quite a big number cannot enroll because of the cost of training. It's very low compared to the costs one would incur when they undertake their training outside Africa, but still we have a few trainees that cannot afford. So that was one of the calls that if we could be supported or through your countries or ministries, take on a few numbers that you can support to undertake the training with the ECSA-HC colleges. Yeah, that's something I've already talked about, National Scholarship Program. Absorption, we did two studies in 2022 and 2023. The rate is high, but the absorption is so low. We call upon the countries to at least find mechanisms and strategies. The executive director of WHO said that they would like to support member states in developing mechanisms and strategies in the region. I think this should be one of them, absorption of our trainees. Guidelines and standards. As colleges, we believe we should not only stop at training, but also develop tools to enhance the quality of training and ultimately the quality of the trainer. Our trainees are trainees during training, but when they finish, they become trainers of their fellow colleagues. So we as COSEXA, and I'm sure the rest of the colleges will follow suit, have developed guidelines and standards to help in the training site so that there is more quality enhancement during our training. We do training and other things, but without examinations, we cannot reach this far. The slide you're seeing is an ultimate goal of our training program, whether 3 years or 5 years, but ultimately trainees have to be examined and graduate to ensure that we know they have qualified and they're in the region. This year, as colleges, we all have various dates of conferences and convocations. CANEXA will be having, ECSACON will be having in September. COSEXA will also be having its annual events. And as ECSA is celebrating 50 years, COSEXA is celebrating 25 years. Our peak celebrations will be in Harare, Zimbabwe. I would like to invite you all. We'll be sending invitations. Please ensure you come. The DG gave us a proverb. Was it cobweb brings down an elephant? A lion. So I've come with another proverb to supplement the Director General's. If you want to go fast, go alone. But if you want to go far, go together. Let us move together so that we can move far as a region. Thank you so much. Asanteni sana.
Thank you very much, Dr. Stella. We recognize the achievement made by ECSA colleges. I know we still have challenges with some of the countries that do not recognize, and Lesotho is one of them. But we will work on that when we get home so that it doesn't become a problem anymore. Thank you very much. I'll now open the floor for discussions or questions, comments. Oh, wait. I recognize Mauritius.
Thank you, Chairperson. I just wanted to have some clarification on the mechanism put in place for retention. Absorption of the trained candidate obviously depend on the government policy and financial issues, but retention is a very tricky scenario. And what mechanism can be elaborated for this region? My second issue is with regard to family doctor courses and training that has to be put in place. As I understand, we have been struggling to put family doctor in Mauritius for the last 2 years. And when it comes to trained doctors in family medicine, family physician, we need to understand that they're 4 years course, 3 years course, and they're specialist courses. And already that many governments are underfunding primary care. How are we going to operationalize the family physician in primary care? I have some amount of apprehension around here. If somebody could explain for me. Thank you.
Thank you, Mauritius. Dr. Stella, maybe you can address the questions raised by Mauritius. Or before you answer, we have Malawi.
My Secretary for Health comment.
Thank you, Honorable Deputy Minister. Thank you, Chair. Just to comment that, to clarify things. So people with qualifications obtained from the colleges of through ECSA are recognized in the government. So we employ that qualification. We have promoted people with that qualification. The National Council of Higher Education mainly looks at colleges that have buildings within the country. So this one is, I can say, a college without buildings. Yeah, we use our hospitals to train people, and beyond that, what we have, government as a ministry, we have now started, funding, budgeting for. Because initially when this started, most of it was externally funded. So that's a comment that I wanted to make, and it has been the greatest contribution to specialists in Malawi. It is a great college. Thank you.
Thank you, Malawi. You want to answer?
We would request the head of delegation from Zambia to handle the one on the retention.
Okay.
And we shall answer the one on training for the family physicians.
Thank you, Chair. On the issues of retention, it has to do with more incentives. When you start giving incentives to the doctors that you've mopped up, they are more likely to stay. So just in salaries, they give them conditions where they're actually able to travel and attend meetings to continue professional development. Those are the issues that allow them to stay. If not, most of the graduates end up going outside where there are better conditions of service. So you really have to up your game, any government, to actually, first of all, when they complete, they are actually in Zambia, they actually automatically become consultants. And so it changes their pay levels.
Thank you. Other part of the question?
Thank you very much, Madam Chair. On the side of the College of Family Physicians, the standard are provided by the College of Health Sciences. where the curriculum is going to be a standard one that will apply to all trainees in the region. Entry qualification will be standardized. All people that will desire to study family medicine or family physician program, they have to comply to the same. There'll be seminars, there'll be workshops, whether in person or online, and then there'll be trainers. These will be certified by the college under the auspices of the College of Health Sciences. This is what is happening in all the colleges under the umbrella of the College of Health Sciences. There's also going to be a cohort of master trainers in each of the countries where the program is going to be run to make sure that there is going to be sustainability of individuals that will offer training to those individuals that will be studying. Then exams standardized. They'll be the same. They'll be sitting the same examination for the whole region, and the convocation is going to bring together all the people that will have trained and passed the examinations. So that is what is going to be happening. So if Mauritius, for instance, wants to join, then the entry path is going to be similar to that which is applying for Kenya, Uganda, Tanzania, Malawi, Zambia, Zimbabwe, and all the other, Lesotho, Eswatini, the kingdom, like all the others. It will be the same.
Okay, thank you. Are there any more comments? Okay, you have the floor, sir.
I would like to really recognize the excellent presentation by Dr. Stella. And when we look at the 50 years leadership and excellence of ECSA, the unique flagship and the most successful flagship has been the colleges. So I think we need to recognize this as we go the next 50 years. My question is, from this excellent presentation, I think there are a very important point came. We need to share the best practices between the old colleges and the new colleges and help each other in moving forward of high standard and quality of vocational competency-based education. So that is one learning which is important, and helping each other as colleges, and especially for us as a new college, we need more help than the others which are already well established. And I look at Dr. Stella and the others to help us with ECSA. The second point which is brought out is the exchange programs, I think, going to be very valuable. How we can exchange expertise between the regions. And then the last point is, how can we bring the college and the programs together, both in the countries as well as regionally? Because sometimes the training goes separate from the programming, and the money is in different places, and the support for each other. So I would really like to emphasize as we go forward that we bring the programming and the ministry's health service deliveries with the colleges together as well, and the colleges more as an integral part of the service delivery of the ministries of health. Thank you.
Okay, thank you for that contribution.
Madam Chair, I just wanted to supplement to the comment that is just made. The accreditation of training site is standardized. This can be shared between us and the colleges that have just come in to make sure that individuals that are training, they receive the same exposure. So when they come for exams, they are not disadvantaged or disenfranchised in the process. The exchange is going to depend on what facilities are available in which country and which are not available in the other countries. For instance, if Tanzania has a robust open heart surgery program, that cardiothoracic, that's going to be for surgery, anesthesia, critical care, nursing, the space will be open for trainees from sister colleges in the region to send their candidates to come and rotate, like it's happening in Kenya in the Tenwek Hospital, where they're way down in the Rift Valley, that has provided a space to take trainees that can be trained in disciplines that are not readily available in the countries where these students come from. The issue of resources, at the moment, each college has a mechanism that makes sure that such funds are collected and they are retained and they are utilized in a transparent manner without any problem. That's why the DG has never made a comment on misappropriation or misuse of resources. Not very much, but the little that we have is utilized in a very, very responsible, manner. We truly have challenges with countries that cannot export resources from such countries. As colleges, we have done internal arrangements to make sure that they are utilized to benefit the welfare of the college so that no country feels like they're supporting other countries. Thank you very much.
Thank you. I think we have exhausted all the comments and questions. Dr. Stella, you still need to respond. Because I thought the question was answered. Yeah. Okay, I think we are nearing the end of our conference. Now we are left with one agenda item, which is official closure of the meeting. I'll hand over to the program director to give the way forward.
Thank you very much, Madam Chairperson. Before we go to the closure, can see people are want to sleep. Why don't we stand for a minute and then we move forward? Can we stand and stretch a little bit? Yeah, I've seen my friend from Eswatini she started. Okay, let's go together to your left, far left. Yeah, okay, we want to write coconut. Okay, let's go. C on your left. All right, that's C. And then you have the O. And then we have another C. And then you have the O. And then we have the T. Ah, okay, there's a U. Okay, the U. This is sort of kindergarten kind of the words. Okay, the U. And then the T. You're like flying now, you know? Yeah, there we go. Thank you very much. Madam Chairperson, before we go to the closing ceremony, may I welcome on stage, with your permission, Madam Chairperson, Dr. Wande, who is going to lead us on the board support AMR control. Dr. Wande, you can approach the podium.
Thank you very much and good afternoon, Your Excellencies. Thank you so much for the sessions today. On behalf of the team at ECSA as well as Africa CDC, we are pleased to welcome the commitment that has been reflected on the resolution on AMR. And we are pleased to welcome our honorable ministers to join us for the pledge commitment on antimicrobial resistance. So this is just a pledge page where we want our ministers and heads of delegation to make a signature on this. This reaffirms your commitment to antimicrobial resistance. It says, I have pledged to be an antibiotic guardian. My actions protect antibiotics. And this is from Africa CDC and ECSA. So following the existing protocol, I will welcome the DG, ECSA, to lead us off with the signing, and we'll welcome the honorable ministers as well for the signing. Thank you. Okay, our DG has advised that we welcome the ministers, so I'll welcome Martin and Evelyn to help me so we can get the signatures done. Thank you.
DJ, some sort of a little background music could do some good. Oh, we can sing holela holela. Some beautiful background music could, yeah. The problem they forget you. Yeah, there goes Tanzania. There goes to the shoot to, Malawi. There goes Malawi. Honorable Minister.
In my pocket.
And then Mauritius.
So torn, torn and free. Thank you, Larry.
That was Kenya, and now Eswatini. Wow, wow. Now the DJ, ladies and gentlemen. Yes. May I ask the honorable ministers and the heads of delegation who have happened to sign to come at least to have one picture with Dr. Wande there. I think this is going to be memorable. Yeah. A round of applause. Oh, somebody did not sign. You did. Yeah, okay. So can you have one picture here?
You were driving me crazy. I don't know you better. You driving me mad.
Can you say holela, holela? Holela, holela. Yes, that is how you smile.
I'm not hanging around. Your way.
Okay, thank you very much. May I now call on the stage? So we start the closing ceremony. And before it, we will be witnessing the handing over of the chairmanship from Kenya to Lesotho. Yeah. So the expert knows how to do it better, and he's just preparing the scene. Yeah. So I welcome the DG, ECSA Health Community Professor Joshua Dambitsia, who will take us through the process of handing over.
Okay. Thank you very much, Mr. Master of Ceremonies. As you recall, when we started the meeting, it was under the chairmanship of the Republic of Kenya. Somewhere, somehow in the background, the reins of power were passed to Lesotho. So what we are going to do in half a minute or so is to symbolically formalize that transition from Kenya to Lesotho. So may I invite the heads of delegation from the two member states to come. And this is the symbol in ECSA Health Community. So it will be passing over. And if I may request each of them to hold their country flag and then ask Kenya to pass over the chair to Lesotho. If you want power, you create a constitutional crisis.
All right, so I think after 1 year of chairmanship, I'd like to now, with all humility and honor, pass over the chairmanship to Lesotho, who have now since taken over. So you can now hold the two. And display the two.
Lesotho is the chair. Thank you very much for your service, Republic of Kenya, and thanks for accepting to guide us in the next 1 year, the Kingdom of Lesotho. Thank you very much.
Okay, to join the high table, may I ask the Permanent Secretary, Ministry of Health, United Republic of Tanzania, Dr. John Jingu, please, for the closing ceremony now. Yes, protocol observed. Madam Chairperson, Vice Ministers Conference, Permanent Secretary, Minister of Health, Dr. John Jingu, DG ECSA Health Community Professor Tambisia, Honorable Ministers, distinguished delegates, collaborating and cooperating partners, ladies and gentlemen, I'm taking the great honor to welcome you now to the last session of official closure of East, Central, and Southern Africa Health Community, 73rd ECSA Health Ministers Conference, and the other activities that came before this. Madam Chairperson, with your permission now, may I welcome the DG ECSA Health Community, Professor Tambisia, to come with the first remarks before welcoming Dr. John Jingu, who will also let you speak with this conference. DG, welcome.
Thank you very much once again. The chairperson of the Health Ministers Conference, honorable ministers, Dr. Jingu and your team, fellow delegates and participants at the 73rd Health Ministers Conference. It is with a sense of gratitude and accomplishment that I stand before you this evening. First, to congratulate all of us for finishing the agenda of this meeting with half a day to spare. We were supposed to finish towards lunchtime tomorrow, but we have managed to complete the agenda this evening. And in the process, I think delegates will not have an excuse not to accept the invitation of the district commissioner to explore the sites around Arusha. We have freed up some time. So Congratulations on doing the work so efficiently. May that be a lesson to us as we embark on our day jobs, to realize that there are things we can do more efficiently if we put our hearts and minds to it. It has been a series of intense activities, and it is only the commitment and dedication by all of us that has brought us this far. But from our perspective as organizers and coordinators of all the activities, we should like to think that they have gone well, notwithstanding any hitches and glitches there may have been along the way. But the pre-conference workshops we started off with went very well, and their outcomes fed into the best practices forum. The walk that we had through the streets of Arusha was quite successful, and suddenly more people within Arusha seem to know what we are about. Many of them pass by our office and see the flags, but they don't know what happens inside there. But now they got to know that we are associated with health. The best practices forum itself was well attended. It was quite participatory. There was a lot of active participation. In fact, on one of the days, the hotel had to chase us from the discussion room so that they close up, because people were still exchanging ideas. And yesterday's function, Bwana PS, was one of the most memorable for some of us. When I called my children in the evening, I told them I'm going to amend my CV and indicate that I was at the 50th anniversary celebration officiated by the Vice President. It is that kind of feeling that many of us got being part of that. So that also went extremely well. And once again, we kept time and finished on time. But again, the ministers sprung another surprise. They decided to bring forward their closed session. And we started it earlier than had been programmed, and that also went well. And today we came in, started, and after tweaking the program a little bit, we have completed everything. So to all of us and to all of you for the active, constructive engagement throughout all these activities, we are sincerely most grateful. I wish to congratulate my colleagues that have been behind the efforts for the establishment of the two colleges that the ministers have approved. You've worked hard. I know my brother Adamson at some point was wondering whether I was no longer his brother, because I kept tossing him back and forth to ensure that he got all his paperwork in order. But I kept telling him, no. If some question has been raised, let's take care of it. Things will go well. Thanks for being patient with me and remaining my brother to the very end. It's not an easy job, given that you have a very demanding day job. And I'm not talking only about Adamson. I'm talking about everybody involved in these exercises. It's a labor of love to push these colleges. And in the same vein, I wish to thank all those who are driving the now 11 colleges. You do this out of the goodness of your heart, for the love of your professional specialty, not expecting any pay, and you do it so well. So for that dedication, thank you so much. May you continue rendering that service. We are hoping, for we must hope in every situation, that somewhere along the line, we may be able, through the various networks you have, to generate some funds so that there is some bit of compensation that is more tangible than the thanks of your patients and students. But we are not yet there. And until we get there, we will keep drawing on your inexhaustible energies. Of course, being mindful that we do not end up being the fulfillment of Aesop's fable of the golden goose. You will recall that when the farmer woke up one morning and found that his goose had laid a golden egg, he was first skeptical and then excited. Then the next day he found another golden egg, still excited. But somewhere along the line, he said, okay, why is it giving me one egg per day? So he decided to slit the goose open so he gets out all the eggs, only to find there was none. So may we not be tempted to push you to the point of collapsing and disappearing from us in the process of trying to get more out of you very fast. The resolutions that the ministers have approved today will guide us, especially as we look towards the next strategic planning period. And we know that with the partnerships that we have, the kind of interests you've expressed severally in the various components of what was presented and approved, we shall deliver. I pledge on behalf of my colleagues that the issue of not knowing what happens to the resolutions, the lack of accountability and tracking mechanisms for the resolutions will be handled very deliberately, and we accept with humility the inclusion of those provisions for us to track and report. We shall do so, Madam Chairperson. I pledge that on behalf of my fellow colleagues. What remains for me then is once again to thank all the ministers and country delegations, all the collaborating partners, all our friends from the various sister organizations. Gratified to have WHO, IGAD, Africa CDC with us up to this time. May we continue with that sisterly or brotherly collaboration as we have been severally asked by the ministers. And I reserve the best and the best of my appreciation to you, Mr. PS, and through you to the rest of the colleagues in the Ministry of Health first, and of course to the entire government of the United Republic of Tanzania and the peoples of Tanzania for your excellent hosting of this function that included the main celebration and the 73rd Health Ministers Conference. Asanteni sana, tunashukuru sana. May I now invite you, sir, Dr. John Jingu, the Permanent Secretary, Ministry of Health, United Republic of Tanzania, to address us as we close this session.
Honorable Chairperson, our Director General, Ex-Director General, honorable ministers, distinguished participants, good evening. Habari za jioni. I'm happy because my friend from Zimbabwe is responding perfectly well. Honorable Chairperson, distinguished participants, ladies and gentlemen, I take this opportunity again on behalf of my minister to express our deep gratitude for having you, hosting you in this beautiful city of Arusha for some 2 days, and for others, our officers, officials, more than 2 days. I hope you have had a good stay in Arusha and we enjoyed your stay here. And I'm saying this with a sense of confidence because otherwise we wouldn't be productive as you have been. The last time I checked my dictionary on what it means by the word efficient, the dictionary told me that efficiency means, or somebody who is efficient is somebody who is able to utilize little resources to achieve the same results. We were supposed to have this meeting for 3 days, but we have managed to do it with the same results. I would say probably best results in 2 days. Indeed, this is what it means to be efficient. And my take is we have been efficient because we are staying well, we hosted well in this beautiful city of Arusha. So please, let's plan to have more of these meetings here. We would be happy to continue hosting you here. We are also happy because of the deliberations, the discussions, the way they were carried out, very engaging, but very productive. The discussion deliberations which allowed us to have the resolutions which we passed them this afternoon. The resolutions which, in my view, they are going to put impactful and significant strides in our health sectors in the region. We believe that the resolutions which we passed this afternoon and which we are going to implement, by the way, they are our only resolutions, so there's no reason why we shouldn't implement them. The DG was somehow casting doubt that probably there will be some laxity in the implementation of the resolutions. I want to assure you, DG, that you shouldn't be doubtful because these are our resolutions. We made them ourselves and we are going to implement them ourselves. And I believe by implementing those resolutions, we are going to put significant strides and lasting impact in our health systems in the region. We are going to be in a position to build health systems which are capable of delivering quality healthcare to our people, quality healthcare services to our people, in preventing and treating existing and emerging health risks and health threats. So I believe when we meet here next year, or it could be somewhere else, but when we meet next time, we'll share some good stories on what we have been able to implement and what the results have been able to achieve. Ladies and gentlemen, we are in Arusha and we are finishing our meeting this evening. I would say I'm very happy because I know our itinerary had of 3 days, well, 3 days, right? So we are not leaving today. I'm sure we're also not leaving tomorrow. I just want to invite you once more to explore the beauty of Arusha. Arusha is known for many things. One, it is known as a hub of tourism and the beauty of Africa. By the way, if you don't know, the cradle of humanity starts here, somewhere in Ngorongoro, Loliondo there. I've been there, but sometimes the two names confuse me. But it's in Ngorongoro, this is in Ngorongoro. There's where they say the remains of the first human being, the Zinjanthropus, was discovered. So probably Adam and Eve, for those who believe in that, maybe they live in Ngorongoro. So please take time, go and see where we all originate. But Arusha is also known as the safari capital of the world. We have one of the best, safari destinations, the national parks, Ngorongoro, Manyara, Tarangire, Arusha National Park, Mount Meru, Mount Kilimanjaro is just around the corner, close. There are many. Take time to explore that. We have museums, cultural centers, markets. We have what would you say, must-visit attractions here in Arusha. So I want to request you and urge you and convince you, take your time to see the beauty of Arusha. You will not regret it. So with those few remarks, thank you again for allowing us to host you very well. And we thank you for the partnership, the friendship, which we have established in these 2 days. I have a big trust that this friendship, these connections will continue. They call it social capital. So let's go and use this social capital to make our work easier. Let's share knowledge, experience on whatever challenges we have. Let's see how together we can achieve in building reliable, robust, resilient health systems in our region. And when you say in our region, it starts from our countries. And as per the theme of this year's celebration, let's go and show leadership and excellence in doing whatever we agreed to do in these 2 days conference. Asanteni sana kunisikiliza, and now without much ado, Madam Chair, they are waiting to hear from you. They are saying this guy should finish. We want to hear from the Madam Chair. Karibu sana. Thank you very much. Check your notes now. Okay.
Somebody took my notes here. I left them. Dr. Yosa, you are the first speaker who came here. I had my speech here. Yes, on that one. It's him. Thank you. I'll start with the acceptance speech for the chairmanship, and then I'll do.
Tanzania. Sasa makitu yenyewe anabaki hapo inaenda kuwekwa stock. Si ndio nakwambia wanabaki hapo inaenda kukaa stock. Wana Tanzania wale. Jana umekatika mara mbili. Iko recording naman. Hapa. Amna, nitanes kwa hilo, kwa mimi kuuliza.
For ably chairing the conference over the past year. I feel encouraged and motivated by the report presented by the outgoing chair that was done in the closed meeting. The strides we have made in the past year are quite notable and representative of our collective efforts towards implementing our agenda in the region. Indeed, there is strength in unity, and let us continue on this path where we support the activities of the health community. It is my undertaking that I shall continue from where my outgoing chair left off and intensify efforts to strengthen the ECSA health community, ensuring that the region moves along together, shares experiences, and learns from each other. The region still faces serious challenges in many aspects. We need to be better prepared for pandemics that may occur in the near future. We should not rest when we still have mothers dying whilst giving birth, when there are infants and children who are undernourished to sustain proper health and growth, when we have a region besieged by infectious and non-infectious diseases, and when large populations still have no access to basic care. It is a fact that whilst one member state may be experiencing difficulties in dealing with a particular health challenge, another may have succeeded in the same area. That is where the regional mechanism becomes effective and relevant in enabling us to learn from each other and address common challenges. And we need to do more of that. Your continued support and retention of membership with the ECSA health community is testament to the fact that you still believe in the efforts of the organization. It is therefore most heartening to note how you highly regard the regional cooperation. I hope that this high regard will translate into resources for strengthening the work programs approved by this conference and for execution by the Secretariat. Honorable Ministers, we have to redouble our efforts to grow the ECSA health community membership and invite other countries to join the community as they have similar principles, interests, and challenges in health. This is particularly important because we all know that diseases respect no borders. Some neighboring countries may not be ready to join our community, but let us continue extending a hand of friendship to them as long as they share common ideals for the sake of the welfare of our people. My predecessor did touch upon the issue of financial stability of the ECSA health community, as indeed has been in our past conferences. As we delight in the progress made and consider various ways of creating a healthy and sound financial base, let us also be thinking of how best to use our resources, the resources we have, in order to realize the most health gains. I also want to encourage the Secretariat to continue focusing and facilitating implementation of priority health programs that would result in lasting changes. This has been quite a hectic week, as some of the delegates, they arrived last week and they've been working tirelessly. And 50 years of ECSA health community really needed to be celebrated in a special way, starting from the health walk, the gala dinner, and we are still here. It's still 50 years of leadership and excellence in regional health collaboration. We have been told about the achievements of ECSA health community in these 50 years, and we truly appreciate the works that have been undertaken by ECSA and the support they've given us in our respective countries. As I've already said, we have many challenges that are facing the region. As has been said throughout this conference, issues of health financing, issues of resources, the NCDs, the imaging and re-imaging infectious diseases, and health emergencies. And we therefore have to build resilient, sustainable, and responsive health systems. We know the major challenge in all of this is health financing, and it's not easy as there are competing priorities in our countries. But we will continue to encourage our governments to inject more funds into the health sector. And as a region, we still have a long way to go. I would like to thank the honorable ministers who made time to participate in this conference. It's really appreciated, but please remember that we still have unfinished business. I would also like to thank all delegates who took part in this conference. I would also like to express gratitude to our partners for their support and commitment in strengthening health systems in the region. To the ECSA Secretariat, I would like to appreciate the work that has been put in the preparations for this conference. And to the government of the Republic of Tanzania, we are humbled by the hospitality extended to the delegates and honorable ministers. And we also thank the government of Tanzania for hosting this conference. And finally, to all the delegates, I thank you all for your participation and wish you safe returns back to our capitals. And with these few remarks, I would like to declare the conference officially closed.
Thank you very much, Madam Chairperson. I thought you could be clapping while standing and at least shake your hand with one person and say, congratulations, we made it. Yes. At least one person or two, tell them, congratulations, we made it. Yes, we did. We did. That's beautiful. Yeah. Yes. Yes. Thank you. I have one announcement to make. May we get seated? I just have a few announcements to make and then we will be dispersing. Dear ladies and gentlemen, distinguished guests, may I make one announcement? Just one announcement. And then the evening tea, that will be our cocktail tonight. We shall be dispersing through that. Okay. Arrangements for transport from your hotels to the airport are made. according to your own time. So when the time comes in for you to leave your hotel, just wait in the lobby. And if anything comes up, you can always contact Mary, Madam Mary, and my friend is Sibusiso. Anything that comes up, you can contact them and they will always be in a position to serve you up. Otherwise, I'm also pleased to be part of this spectacular event, and I'm so thankful. I have made a lot of friends across Africa, and we had a great time yesterday. May I also welcome you to Tanzania again, and especially Dar es Salaam. I live in Dar es Salaam, so if you come to Dar es Salaam, let's just chill out. Ladies and gentlemen, this is the end. Tupo na cocktail ya chai. We have a cocktail of tea, tea cocktail. Let us join up there as we say, thank you so much. Karibuni tena. Somebody help us with this.